I'm going to mute everybody.
Yeah, please.
Binil sir, unmute and you can start, sir.
Yeah, we can start now. Good evening. And Nasser sir, please start.
Yes, good evening all. Welcome to this this evening CME of ISA Kerala State Chapter. I request Dr. Venkatagiri KM, President-elect ISA National, for a brief introduction. Dr. Giri, please.
Giri sir,
Dr.
please
Giri?
unmute and talk, sir. Please unmute, Giri sir.
Yes, I have unmuted. She has not made you co-host. Now she has made. Now I can unmute. Okay. Good evening, President Dr. Nasser, National President Dr. Joshi, National Secretary Dr. Naveen, past President and Academic Chairman Dr. Balabhaskar, our esteemed faculties and chairpersons, Dr. Rebecca Madam, Dr. Elsa Madam, Indrani Madam, Manimala Madam, and Lakshmi Kumar, and our chairpersons, Divekar Madam, Jayashri Sood Madam, Manjushri Madam, Sunanda Gupta Madam, Sarama Madam, and Shamsar, and all our friends and everybody. And good evening to you all. We thought we will have a change from our previous schedule and have a meeting with all women CME. It just thought some idea came to me and told with the Binil. He also said, okay, sir, we will have one with that. So this time we are having with the different topics from different persons, and all have kindly agreed. All are veterans, very seniors, and expect many more people to join us. I welcome you all for this webinar, and it will be useful for all, I think, with all veterans, people are interested to hear. So I welcome you all and request, this is the 14th in our sequence, and we'll have many more in the coming days, and it will helpful our friends and colleagues all over the world to update their knowledge. Welcome you all and request President for further deliberations. Thank you.
Thank you, Dr. Venkatagiri. Good evening, respected officials, seniors, and teachers. Welcome to this 14th, I can tell it, a special CME for first all-women CME. We have a team of eminent senior faculties from all over the country. I'm very happy that there is a very presence for the CME, all CMEs of ISA State Chapter. We have a guest of honor, Dr. Muralidhar Joshi, President, ISA National, the Honorable Secretary of ISA National, Dr. Naveen Malhotra, Dr. S. Balabhaskar, Chairman, Academic Committee, ISA, President-elect ISA National, Dr. Venkatagiri. Sir, I'm really happy and honored to welcome you all because you are the backbone for all our continuing high standard academic program. I take this opportunity to welcome you all to this meeting. Now we have a team of eminent faculties, all women from different parts of the country. We have Dr. Rebecca Jacob, who is the anesthesia coordinator and senior consultant, Columbia Asia Referral Hospital. She is talking on anesthesia for children with cleft lip and palate. And this session will be chaired by Dr. V.M. Divekar, who is from ex-HOD TN Medical College, Mumbai. I'm very happy and honored to welcome you, Madam Dr. Rebecca Jacob and Dr. V.M. Divekar to this meeting. On behalf of ISA Kerala State Chapter, I extend you a warm welcome. We have the second talk on anesthesia for infant abdominal emergency surgery. Dr. Elsa Verghese, Professor of the President of the Indian Society of Pediatric Anesthesiologists. She, Madam, on behalf of ISA Kerala State Chapter, I extend you a warm welcome. And both the sessions will be chaired along with Dr. V.M. Divekar, Dr. Jayashree Sood, who is the Chairman, Institute of Anesthesiology, Sir Gangaram Hospital, New Delhi. Dr. Indrani Hemant Kumar, who is the HOD of Anesthesia, KEM Hospital and St. GS Medical College, Mumbai, and President-elect RSSCP, talking of a very interesting subject, a challenging case as a clinical scenario in our day-to-day practice, anesthesia for a difficult airway patient after failed regional anesthesia. Madam, I extend you a warm welcome on behalf of ISA Kerala State Chapter. Dr. Manimala Rao was the Director of Medical Education and Academic, KIMS Hyderabad, former Professor, HOD of Anesthesia, Critical Care, and Dean, NIMS Hyderabad, speaking on burnout among anesthesiologists and critical care physicians. Dr. Manimala Rao, I am very happy and proud to welcome you on behalf of ISA Kerala State Chapter. These two talks will be chaired by Dr. Manjushri Rai, Principal, Calcutta National Medical College, past President of ISA National, Dr. Sunanda Gupta, past President of AOA, Professor HOD of Medical Uday. I welcome you to this event CME of Kerala. We have our own Kerala State, Dr. Lakshmi Kumar, who is based with us in all our CME from HOD of Anesthesia, Amrita Institute of Medical Sciences, Cochin, working on a recent anesthesia consultation in patients recovered. And this session is chaired by Dr. Sarah Abraham, who is the ex-D of Government Medical College, Kottayam, and MOSC Medical and present HOD of MOSC Medical College and past President of ISA Kerala State Chapter, and our President-elect Amshad, who is a Professor and HOD of Government Medical College, Teacher. I extend you a warm welcome, Dr. Lakshmi Kumar, Dr. Sarah Abraham, and Dr. Samsad Begum being with us this evening for the CME. I'm very happy to welcome our Secretary, Dr. Bill Isaac Matthew, who is the backbone for all this, organizing all these CMEs. And welcome all members, the office, and all delegates. Once again, I am really happy and honored to welcome this CME of Kerala. And I hope you'll enjoy the session from a team of eminent speakers on various clinical scenarios. I request Dr. Muralidhar Joshi, President ISA National, for a few words. Dr. Joshi, please. Dr. Muralidhar Joshi, President ISA National.
Yeah. Hello.
Yes, sir, audible. You're audible, sir.
Yeah. So I'm driving actually, so I don't want to be like visible because I'll be in the radar of the police. So just wanted to congratulate the ISA Kerala State Chapter, Dr. Nazar, and then Dr. Binil and our own Dr. Venkat Giri, President-elect, for thinking of having a woman-specific CME. Probably would have been happy if the topics are also specific towards women. Probably that could have been much more. Probably next time they could think about that one. But the esteemed faculty, what they have assembled is phenomenal, and it's great. It's great, and my special thanks to Dr. Giri for taking initiative, and also Dr. Binil and Dr. Mazhar, of course. And I also appreciate Dr. N. Malhotra, our Honorary Secretary, encouraging, and our Dr. Balabhaskar, Chairman Academic Committee, for being part of all these things, and but eminent faculty and a lot of scientific content. I don't want to be obstacle for these kind of thoughts and all. Please, all the best for the event. We are always with you, and definitely request Dr. Giri to have some more probably women-oriented topics, something like anesthesia and all those things, responsibilities, probably professional well-being point of view, and other healthcare issues and all. Maybe that might be much more fetching, and that might be much more interesting for the next CME. All the best once again, ISA Kerala State Chapter. Salute to you. All the best. Long live ISA. Jai Hind.
Thank you, Dr. Muralidhar Joshi. I request our
Nasser, sir, you are not audible.
Hello.
hello.
Requesting to Dr. Naveen.
Naveen.
Naveen sir, please.
Thank you, Dr. Nazar, and heartiest congratulations to you and Dr. Benil and Dr. Venkatgiri, President-elect, for organizing today's webinar on focusing on all women. President Dr. Muralidhar Joshi, President-elect Dr. Giri, Dr. S. Balabhaskar, Chairman Academic Committee, and other office bearers of ISA. It's really pleasure and honor to be talking in front of Madam Divekar, past President ISA National, Dr. Manjushri Ray, past President ISA National, and majority of the speakers and chairpersons are our teachers, and we have been listening to them as students, to be honest. So with folded hands, warm regards to you all. Some of you, we are working now in colleagues, but majority of you have been our teachers, Dr. Madam Sood, Dr. Sunanda Gupta, Dr. Rebecca Jacob, Dr. Elsa Varghese, Dr. Manimala Rao, and we're closely working with Dr. Indrani Himmat Kumar now and Dr. Shamshad Begum, Dr. S. Abdaham and Dr. Lakshmi Kumar. So topics are excellent on pediatrics, airway, burnout and COVID, and heartiest congratulations to the Kerala State branch for organizing today's webinar, and warm respect and tributes and regards to all the chairpersons and the speakers. Thank you very much. I'm very sure that it will be a very nice academic interaction between the esteemed faculty, chairpersons, and the delegates. Thank you very much. Congratulations again. Long live ISA. Jai Hind. Thank you.
Thank you, Naveen sir. Now,
Dr.
Dr. Balabhaskar, Chairman, meeting sir, from your side.
Yeah,
Dr.
sir,
Balabhaskar,
good evening.
please, sir.
Yes, sir. Good evening, Nazar sir. Thank you very much. And also Dr. Benil, Secretary of ISA Kerala, and President-elect Dr. Giri. So in the presence of our Honorable President, Dr. Muralidhar Joshi, and Secretary Dr. Naveen, I'm very lucky to be here for today's program, because today's program probably is equal to about 100 regular programs. 100 regular programs in the sense that we have the most knowledgeable, senior most people among us. They are going to share their knowledge. And when I say, yes, they are going to share their knowledge, but I will say they are also going to share their wisdom. So we have to take up the wisest part of the education here also. It's a lesson for us also, as Dr. Naveen was telling. We heard all the senior most colleagues speak in various fora. So it's an achievement, and therefore I congratulate Dr. Venkatgiri for getting all our senior members, lady members, into a single day's program. So congratulations once again, and thank you very much, and I wish all the best for today's program. Thank you.
Thank you, Balabhaskar sir, for your kind words. Now we will straight away move on to the academic session. I request Dr. V.M. Divekar and Dr. Jayashree Shaw to take over the first two sessions as chairpersons or moderator and initiate the academic program. Sir, over to the chairpersons.
Before that, for everybody's information, if this day was without COVID, we should have been in Ahmedabad in the inaugural function of this conference, our national conference. Unfortunately, this year we are not having. This day we all should have been.
Yeah.
Only Mr. Joshi would have been presiding over the inaugural function of the conference. And when he's not there, we all would have been there. But now we are enjoying this CME on the CME day and conference day. So we thought that all the senior veterans should be there on this day. Thank you. There are many seniors.
Thank you, Giri. Now over to the chairperson. Yes. Please, Giri, please.
Hello, can you hear me? Can you hear me?
Audible.
Good evening, everyone. And it's been a long time since I've met many of you, all the women, I mean. And I'd say it's a very unique situation where all the speakers and the chairpersons are female, and all the presiding officers are men. Anyway, I think one thing is not mentioned about Rebecca is that she is also one of the chief persons in Smile Train, and that is not mentioned here. Yeah, and I now request Rebecca to start her talk. And incidentally, My first specialty in anesthesia began with plastic surgery and lips and palates. Okay. Yes, Rebecca, you can.
Thank you, Dr. Divekar. I would share my screen. Today, I'm going to speak on cleft lip and palate. And as Dr. Divekar said, I am a member of the Medical Advisory Council of Smile Train India, but I'm not being paid for giving this talk. So the talk is on my own. Now, facial cleft is the second most common congenital abnormality after clubfoot. Good to note that facial development occurs between 6 to 10 weeks of fetal life. And as this is quite early, other organs that are developing at the same time may also be affected. Looking at the embryology of the face, there are three growth centers. There's the medial nasal process, the lateral nasal process, and the maxillary process. The cleft occurs due to failure of contact of the medial nasal process and the maxillary process. This can lead to anything from an incomplete cleft lip to severe craniofacial cleft. Now, there are different types of cleft. There are the unilateral ones, which may be incomplete or complete. There may be bilateral cleft lip and palate, or there may be a facial cleft, which is complete. Now, who is more prone to develop a cleft? Children of diabetic mothers, children of elderly fathers. The male to female ratio of cleft lip and palate weighs heavily towards the male. But if it's an isolated cleft palate, females, it occurs more commonly in females. There are environmental risk factors, which include alcohol, anti-epileptic drugs, rubella virus, and many others. Now, there are certain problems which occur in patients, especially clefts of a palate. There's regurgitation and repeated aspiration. They have repeated respiratory infections, airway obstruction, mainly because of the tongue being rather large, and small jaws, feeding problems, giving rise to malnutrition and anemia, and many associated syndromes. So it's important to look for a history of regurgitation and repeated aspiration. Repeated chest infection, chest x-rays may reveal this, and high WBC counts. Now, malnutrition and anemia, we expect the babies to look malnourished in general, but don't miss the finer points of malnutrition. Look at the skin, look at the hair. The hair may be more reddish and coarse, and in general, they are rather undernourished. For airway obstruction, the mothers may tell you that they snore, but the child gives you a clue because he likes sleeping prone so that his tongue comes out of his mouth and he can breathe better. Airway obstruction can lead to chronic hypoxia, which in turn could lead to cor pulmonale. The pathophysiology of airway obstruction is due to the posteriorly placed tongue along with the hypoplastic mandible. This significantly reduces the size of the posterior pharyngeal airway. Now, the associated syndromes most commonly are the Pierre-Robin sequence. What does this entail? There's mandibular hypoplasia associated with glossoptosis and a cleft palate. It's important to assess the mentohyoid distance because this tells you how much place there is for us to move the tongue out while we are intubating. Now, oral clefts are part of a specific syndrome 15 to 60% of time. Now, there are more than 200 syndromes which have clefts as part of the syndrome. I don't remember all of them, but the most common, as I said, is the Pierre-Robin sequence. Now, what do we have to worry about? Because most cleft surgery is done in infants. And it is important to remember how a child differs from an adult. His airway, both anatomy and physiology, are different. His fluid and electrolyte balance, very, very different. Glucose metabolism, he has a tendency to hypoglycemia unless you give too much glucose and cause hyperglycemia, which is iatrogenic. Temperature maintenance, they are very poorly maintained. Their psyche and parental involvement, and very often their interference. So during the pre-anesthetic check, we focus on pre-medication and fasting orders. But remember, we have to check and recheck the child for fitness for surgery, evaluate the disease, not just the cleft lip and palate, but look for malnutrition, look for obstruction, look for chest infection, and so on. Decide on the optimal anesthetic and allay the anxiety. In the older child, you have to talk to the child and allay his anxiety. The younger child, it's the parent's anxiety you have to allay. Now, pre-op fasting, you may follow the 6-4-2 rule, but don't just write 4 hours before surgery or 2 hours before surgery. Specify the time so that the nurse and the mother knows when to feed. Intraoperatively, decide on the choice of fluids, how much, and do we need glucose? The smaller babies may need glucose, the older one may not. And post-operatively, what are you going to think about for fluid management? Pre-medication depends on the age of the patient and how you're planning to separate the patient from the parents. If the child has a greater degree of airway obstruction, do not consider a sedative pre-medication in the ward. Also check on the availability of good nursing care in the preoperative area. What are the anesthesia problems? We have to think about induction. If there's an IV already in place, you can give an intravenous induction, but very often we choose an inhalational induction. What are the problems with mask ventilation, laryngoscopy, sharing the airway with the surgeon, intraoperative monitoring and access to the monitors, access to the patient, and extubation? So let's look at these problems one at a time. This child would definitely have a difficult mask intubation. Remember, when we do a very small child with a big head, it's very good to have a small roll under the shoulders. In the adult, we like to put a pillow under the head and then extend the head on the neck so that the 3 axes that we are very familiar with would all be in the same straight line so that you could visualize the glottis easily. On the other hand, the child needs this little roll under the shoulder to get his axes in a straight line, not a pillow under the head. Thus, this is what you need to do. Put the roll under the shoulder. Now, direct laryngoscopy, you want to bring the line of vision from the eye straight to the glottis. It's easier said than done when the child has a small hypoplastic mandible and a large tongue. A child with a Pear-Robin sequence would cause problems. And more so if the child has a prominent premaxilla. A premaxilla like this would have a single artery supplying the premaxilla, and you have to be very careful about not snapping that premaxilla. What happens is there's a tendency for the blade to slip. Sorry, can you not hear me?
No, ma'am.
We can hear you, madam. We can hear you.
The problem is that the laryngoscope blade tends to slip into the cleft, and then there is not much space within the mouth for you to visualize the glottis. So what do? We may use a gauze pack in that cleft. You may use a blade with a higher flange like this one. Or you may go to a paraglossal approach and avoid the cleft completely. Now, even after viewing the cords, you may find it difficult to intubate because the space in the mouth is very limited. So remember to angulate that tube to an anteriorly placed trachea, and so we very often use a stillet. Make sure you have all the basic equipment, and also you may have to get equipment out of the difficult airway cart. The advanced equipment would be video laryngoscopes, whichever one you are comfortable with. Always try and use a video laryngoscope in a straightforward case before trying it out in a difficult to intubate case. Keep the rescue devices available. I really like the LMA Supreme because it's very easy to put in and ventilate the child while I'm thinking of what to do. So to summarize, preparation is the key. You have the subjective, objective, assessment, and plans. History, physical examination, especially the airway. Discuss with the primary surgeon what you're planning to do, and when you run into trouble, ask him for help early, him or her. Equipment, again, soap, suction, oxygen, airway, and your drugs. Your difficult airway cart with the rescue devices, and arrange for help. Don't sit on your pride, always ask for help. What happens intraoperatively? I like to fix the tube this way and to cover the eyes like this so that the surgeon can see the child as a whole. Make sure that the connectors are way out of the surgeon's field. Now, if you're doing a palate, the position you want is hyperextension of the child's neck. In this position, it's very difficult to intubate the child. And therefore, for intubation, I usually put a pillow under the head ring and bring the head up to neutral. I also would do this if I have problems with the tube intra-op and the tube is coming out or slipping out. I would have a pillow always ready to slip under the head to bring the child back into position where I can intubate. Now, access to the patient and monitors is very, very difficult. So make sure that monitors and your IV sets are well fixed and you can access the child's chest to listen to the child. Now we're sharing the airway with the surgeon. And when they put the gag, there's a possibility of the tube kinking. And when they take out the gag or rearrange the gag, there is the possibility of accidental extubation. So be ready with another tube always available and that pillow for the head in case of problems. Now the throat pack, some surgeons use it. For a palate, I don't use a throat pack. For a lip, I do because of the position of the patient. Some surgeons also like to put these lateral packs after they do the clefts. Now, these lateral packs, it would be better if you had a thread on it, brought out at the end of surgery and fixed to the side of the cheek. Otherwise, this could get dislodged and can cause airway obstruction after extubation. Your post-operative problems could be bleeding, airway obstruction, bronchospasm, laryngospasm, aspiration and electrolyte imbalance, and not to forget glucose imbalance. A child may also have seizures. We've noticed it if there's hyponatremia. If you anticipate an airway obstruction, do ask the surgeon to put in a good tongue stitch and fix it outside on the child's cheek. I usually ask them to put a nasopharyngeal airway, but I ask the surgeons to do it, and they're very good about fixing it. Post-extubation stridor could be due to edema of the upper airway caused by large cuffed endotracheal tubes or multiple attempts at intubation. Treatment, CPAP, humidified oxygen, aerosolized adrenaline. We don't have any other form of adrenaline, but our regular adrenaline works just as well. Intravenous steroids, dexamethasone, and nebulized steroids. And with that, I end my management of clefts. Thank you.
Ma'am,
Ma'am,
good
unmute,
evening.
ma'am. Ma'am, unmute, ma'am.
Dr. Divekar, you're muted. Yes.
Hello, ma'am.
Yeah. That was an excellent talk you gave us with lovely illustrations. And I'm sure this comes from the senior most pediatric anesthetists in India. And of course, I also, it took me back about 50 years ago when I started my career with plastic surgery, where when I instituted the Department of Plastic, I was the first anesthetist, so it was quite a challenge at that time with ether and other agents. Yeah. I think Jayashree is there now.
Yes, ma'am.
Would you like
I'm there. Good
Yeah.
evening, ma'am.
Good evening. Long time. Yeah.
Long time, ma'am. Yes. Yes.
Can you continue with this?
Yes, ma'am. Thanks a lot, Rebecca. That was an excellent lecture. And you made it so easy, but definitely it's a very, very challenging case. Thanks a lot. I think we'll take the questions later. For our next talk, we have another very eminent faculty speaker. She's Dr. Elsa Verghese, and she was the former professor and head of anesthesiology at the Kasturba Medical College, Manipal. And she was also at Chennai at the MIOT International Hospital. She has been the past president of the Indian Association of Pediatric Anesthesia, and of course has attended and is a faculty in so many national, international conferences, and a very good friend of ours. Welcome, Elsa. And she's going to be talking about a very important topic again, anesthesia for an infant abdominal emergency surgery. Again, a very, very challenging case. It's an infant, it's an abdominal surgery, and it's an emergency. So I'm sure Dr. Elsa will be pointing out all the salient features. Elsa, please.
Well, good evening, everyone. And it is such a joy to be part of this group, all with old friends. And I have to thank the ISA Kerala and especially Dr. Venkatagiri for making this happen. As Dr. Sood mentioned, I'm not sure about you, but I remember when I was a resident and a junior consultant, I was always, it was a nightmare for me if there was a neonate with a distended abdomen who was coming for an emergency procedure. And my guru dinned it into my head on how important it was to manage these very delicate little babies. And so today, I hope to discuss this topic under various questions. The first of it being is that why is it important for us as anesthesiologists to know what is the diagnosis? Because, and why is it, how is it that the diagnosis affects the general condition of the baby? How does it affect circulation? How does it affect respiration, which are all very crucial indices on how sick the child is. We also need to know why it is so important to assess these babies very acutely preoperatively. And I'm hoping we, at the end of this lecture, will understand why. The main reason being is that we have to be acutely aware and have the knowledge and the background of knowing how to deal with fluid and electrolyte resuscitation. And touching on some of the the risks associated with specific surgeries. So infants or neonates how do they present? How do you know that it's an abdominal problem? It's usually because the baby is vomiting or has got gross abdominal distension, like you see here, or the baby has not been passing meconium, or there's a delayed passing of meconium. And that's when you suspect there's a problem in the gut. And it's important for us to know where the problem lies, because the physiological after effects depend on this. So if there is, say, for instance, an upper gastrointestinal obstruction, the predominant feature is vomiting. And what's the implication of this? Again, it depends on where it is the obstruction or the problem. If it's upper end of the gut, the duodenum or the pylorus, it's often a clear vomitus, but one needs to know that there's a significant loss of chlorides, of potassium, of sodium, and of hydrogen ions. And these babies will tend to present with a metabolic alkalosis. Now, if it is below the duodenum, you have this terrible bilious, copious vomitus, which have pancreatic secretions. There's often a loss of bicarbonate with the resultant metabolic acidosis. So we need to know where the lesion lies. And significantly, we know that all this can ultimately lead to shock, and we need to look out for signs of shock, whether there is acidosis, are there bloody stools, because at the top of our mind, we need to suspect, is this an acute volvulus or is it a gangrene? And we can't delay this kind of surgery. We need to take up this child as soon as possible. And as anesthesiologists, it's important that we know how to distinguish this. Now, if it's lower bowel obstruction, very often the predominant feature or the predominant feature is abdominal distension. Now, what are the implications of this? Well, you have a distended gut, it pushes up the diaphragm, and therefore it causes a limitation of breathing and respiratory distress. And you have fluid which is pouring into the bowel, bowel and also into the bowel wall, and that can result in hypovolemia. And bowel edema finally kind of it breaks down the wall of the bowel, and you have the problem of perforation and peritonitis. And in a very long-standing situation, you can have, like in Hirschsprung's, you can have a toxic megacolon. So it's really important that when you see the baby as an anesthesiologist, you do a very quick review of history, of physical exam, what has been done so far to the child after admission, and have any lab tests or radiology been performed. And I would just like to stress on how are you going to assess, and how would you assess this baby? So it's important to know the gestational age. Obviously, if the baby is premature, there are specific problems related to that. Well, how was the birth history like? Did the child aspirate, and are there associated respiratory problems? How significant are the presenting complaints? Are there any associated anomalies? Because one needs to know that you have one anomaly, you're likely to have others. And another really important aspect is how adequate was the resuscitation. And you need to not only just examine the child, you need to look, is he lethargic? Is he dehydrated? What's the respiratory rate like? Is it very rapid? Has the child aspirated? Is there nasal flaring? Does the child require oxygen? Is the saturation low? Is the heart rate very rapid? These are all signs that we would worry about. And you look at the patient's records. You need to know what is the weight, and if the mother is slightly intelligent and knows what the birth weight was like, or what was his weight when it was last seen by a doctor, you would know how much weight the baby has lost, what were the drugs that have been given, how much fluid was advised, and how much has actually gone. You would be surprised to know that there can be quite a big discrepancy between what has been asked to be given and what the nurses have actually given or may not even have started. And then if the child has had an X-ray, has the child aspirated? If the child is intubated, you need to also check the position of the tube. And there are times when it's not too much of an emergency where the child might have had a CT scan, and you need to also have a look at that. So I'd just like to give you a quick overview, because this doesn't take more than a few minutes. And even if you've seen the child in the ward, it's worth just doing a quick check before you actually induce the child. So what do? You go from head to toe. Look at the general appearance of lethargy, fontanelle. Are the eyebrows sunken? What's the mucous membrane like? Is there very rapid, shallow respiration? Have a little pinch of the nail bed and look at the capillary refill time. And if it's delayed, put your hand on the brachial pulse, and is it a nice bounding pulse or is it feeble? Check the blood pressure. Very often these are not checked in the wards, but try and get it checked. Look for the skin turgor. That's also a good sign. And see whether the child has passed urine or not. And this is really important. And with this quick check, you can assess whether the child is dehydrated or not. And if the child is dehydrated, there are clear formulas that you can follow depending on how much weight loss there is from before and into mild, moderate, and severe. And you can calculate the fluid deficit. And the idea being is that you give half this calculated amount within the first hour, and then the subsequent amount slowly. Now, the question is, what fluid do I give? And the answer is, if the child is dehydrated, you need to give isotonic saline. That's what you give. How much do you give? Well, fairly rapidly, you can give about 20 to 40 ml per kg. And how fast do you give it? Well, you start it off as fast as you can immediately, and you give this volume over a period of 1 hour. And then once you know that the child's status has improved in terms of hydration and vital signs and has passed urine, then you start giving the remainder of the fluid calculation that you have calculated earlier over here. You then give the remainder over the next 24 hours if you have the time. But you can continue this resuscitation into the intraoperative period if you have to take the child in rapidly. At this point, I think all of us anesthesiologists need to know which are the babies that we need to take up immediately and which are the babies where we can afford to resuscitate, and even though they require surgery. So we need to have red flags for these. Malrotation with volvulus, you can't wait. You rapidly give your whatever fluids as fast as you can, bring the baby in. If there's intussusception with perforation or ischemia, if there's obstruction or an incarcerated hernia, especially in a premature or any baby, take them in as fast as you can. If they're not being, you can't relieve the obstruction. And if there's a Meckel's that's bleeding, or if it's a torsion testes or an ovarian torsion, these are the ones that you do not delay, and you bring the baby in as fast as possible into the OR, do as much of your fluid resuscitation as you induce and as the child is being prepared for surgery. So don't say, I'll come back tomorrow. Now, in these situations, if there's no volvulus with malrotation, if there's an intussusception, but with failed reduction, you need to, if they could reduce it, they may not come for surgery, but if there's a persistent intussusception without ischemia or perforation, you can afford to give some fluid. And intestinal obstruction without peritonitis, if there's an inflamed Meckel's, and pyloric stenosis, perforated appendicitis, all of these you can give some fluid before you proceed for surgery. And in addition to giving this fluid resuscitation and rehydrating the child, one needs to know that these babies also, especially the younger ones, require dextrose. So if in a very small baby who's 1 to 3 days old, you would add, in addition to this, your maintenance requirements of 10% dextrose in, say, a small amount of saline. If the baby is more than 3 days old, you can go from 5 to 10% with a higher concentration of saline, and you may have to add bicarb and potassium. And once the child baby is a little older, you can go on to 5%. These are for maintenance fluid requirements in these babies. And what I would like to stress is that one should have on floor in a separate line this maintenance fluid requirement. You should always have 2 lines when you're dealing with a baby who comes for an abdominal surgery. Now, I've been stressing a lot on why you need to make this decision on which babies do you not take up and which babies do you take up as soon as possible. And the important thing to know is that the morbidity and mortality is greatly reduced with optimal perinatal care. And most neonates, especially the ones who are mentioned earlier, who do not have a perforation, who do not have gangrene, who are not bleeding, and who are not acidotic, those are the ones that you can stabilize sometimes over 24 to 48 hours before you take them up. But these situations are absolute emergencies and you need to bring the baby in. You can't delay because they go on to gangrene. I have to stress that, as a person dealing with babies, you have to learn how to communicate with surgeons. I often get asked, oh, the surgeons don't want this. The surgeons say you have to take up. And you know that you have to learn that they need to trust you. They need to trust your clinical acumen, and you need to communicate your concerns, and they need to communicate their concerns so that finally you do the best for the baby. Now, before you actually take the baby into the OR, there are some checklists that you need to go through. You need to know what is the baby's ventilation like. Has she, is the baby intubated? Is the baby mechanically ventilated? What are the settings? Is she on oxygen? What's the perfusion status like? What are the electrolyte imbalance like? What has been given? And most of these babies would have had a Ryle's tube inserted. You need to look at what is the aspirate, what's the amount, because you might have to add this on to the requirements of fluids. Is the baby in sepsis? If so, what antibiotics, how much, when was the last dose given? And you need to ask for repeat labs once the child has been resuscitated to know what is the baseline status before you induce anesthesia. The other question often is what is the hematocrit? And if the hematocrit is low, then you might need to transfuse these babies preoperatively, and they might also need platelet transfusion. And one important aspect is consent, because you can't imagine how distressed these parents are. And it's very important that you spend the time to explain. If the baby is very sick, then they need to know the critical conditions and that you're going to try your best, but there are possibilities that the child may require ventilation post-op, etc. But more than that, be compassionate because they are so distressed. Right. When is it safe to induce anesthesia? So you need a good pulse volume and a blood pressure that's measurable and good. You need fairly normal electrolytes. The child needs to be normal glycemic. So it's important that you gel the blood and preferably passing urine. And also you need to know whether blood products are available before you proceed, because very often these children do need blood. How is the child being transported? It depends on your center, how well equipped you are. Do you have incubators or do you not have incubators? This child obviously was very sick on various pumps, and I can't even find where the baby is. And how do you've got to find him somewhere here in the whereabouts. So there are various ways in which these babies are transported. But it takes time for you, once you decide you're going to take up this child, for you to prepare. And one of the most difficult things to do is to maintain normothermia, which is so critical in these babies. And you need multiple types of equipment to keep them warm, and all this requires preparation. And the best thing would be to have an overhead warmer and to bring the baby in with an incubator. And you need to take meticulous care as far as asepsis, about having appropriate drugs and volumes. You need to make sure, especially if you're in a center that you don't do babies very often, you need to have the appropriate size equipment ready to go to put onto your patient before you don't look for it once the baby arrives. You need to have everything ready. And what is so crucial is you need to have a separate suction for yourself. You don't share it with the surgeon. We have had situations where they say, no, ma'am, we'll bring it, we're using it somewhere else to bring it in. No, you need to have it there. You need to have at least 2 suctions available in the OR. So what are your intraoperative concerns? The babies come in, and one of the first things you do is you aspirate the Ryle's tube, because you want to make sure that the stomach is as empty as possible. You do not use the wall suction because it is very strong. You can actually suck out the mucosa of the baby. You need to use a syringe, and you need to suck out the Ryle's tube prior to induction. And you also need to put it into a bag, and you need to keep the proximal end open. And you also need to tape the bag to the table so that it doesn't, the weight of the aspirate doesn't pull the Ryle's tube out. So lots of little things to remember. What is very often performed is a rapid, or more often a modified rapid sequence induction. And this is because the baby may not tolerate a period of apnea, and you need a very, very gentle mask ventilation and rapid intubation. Now, most pediatric anesthesiologists would avoid cricoid pressure in these small babies because it distorts the trachea, and the likelihood of you getting a first shot intubation may not happen. Now, would you use the cuffed or an uncuffed endotracheal tube? The question is, it's really up to you, but I would prefer, if there's gross distension, if you're doing surgery involving laparoscopy, I would prefer to use a cuffed tube. Preferably, one avoids nitrogens, the nitrous oxide, so use an air-oxygen combination. And one has to be very cautious with the inhalational agent in these babies. They can be very sensitive, even to sevoflurane, because of the cardiovascular depression. So you need to be careful in titrating the dose of your inhalational agent. What most anesthetists would recommend is to be a combination of a regional with a general anesthetic, depending on whether this child will tolerate a caudal, etc. And it's important that if you're especially doing anterior abdominal wall surgery, or if the laparoscopic surgery, that you provide adequate muscle relaxation. And if the baby is very sick, then he's not going to tolerate even induction. So you might have to do an awake intubation and an opioid-based anesthetic. So analgesia is crucial. It's important that you stick to the doses and you don't overdose these babies with local anesthetics if you're giving a block. Acetaminophen is the drug that's given to neonates and small babies. And what's important to remember is that the dosage is less the more premature the baby is. And opioids, of course, can be used in smaller doses, but if the child is very sick, you might have to go up to high doses, this being the primary anesthetic, and then this child would obviously be electively ventilated. If you do have remifentanil, then that, of course, the effect wears off more rapidly, and that would be preferred in a neonate. Now, what are some of the challenges of maintaining normovolemia? Because with abdominal surgery, there's a constant loss of fluid by evaporation onto the drapes, etc. So this is why it's so important to have 2 IV lines, and you have a constant maintenance fluid going in one line on a pump, which you calculate based on the type of surgery. Do you need 6 ml per kg or 8 ml per kg or 10 ml per kg? Now, in addition to that, depending on what's being lost, you need to give boluses of ringer lactate or blood products. So how do you decide when to give a bolus? And for this, you've just got to be watching the baby very acutely, not the scalp. You've got to be actually having a hand on the brachial pulse. You need to be watching the capillary refill. You also need to pop your head over across the screen and watch what the surgeon's doing and look at peritoneal pulsations. And if they're not there, it means that there's not adequate perfusion. And you'd be surprised, you just give a little bolus of blood or ringer lactate, and you find that they come pumping back again. And that's a really good sign, because you can't always go by heart rate. and the blood pressure may not record if the pressure is low. Now, if required, you may need to start inotropes. So the other problem one often has is how do you decide on how much blood loss there is and when do you replace? Generally, you need to maintain the hematocrit levels more than 30, but if it's a 30%, but if it's a very sick neonate or baby, you probably want it a little higher. Now, blood product replacements really depend on the underlying illness. For instance, if there's a gangrene bowel or if there's been a bleeding Meckel's, you would probably even start it from the word go. And also depends on how invasive the surgery is. But generally, you would start transfusing if the blood loss is more than 10% of the blood volume. And it's recommended that for small babies, you do not transfuse blood that's more than 1 week old, and it should be irradiated. And the general guideline is look at the swabs, look at your clinical parameters. You can't go by what's in the suction tubing because that itself might be the entire blood volume of the baby. And the general teaching is that if you give 4 ml per kg of packed red blood cells, it usually increases the hemoglobin by 1 gram per deciliter. Now, there is a caution here that when you give a large volume of blood, then these babies do not can't break down the citrate, and they can develop citrate toxicity. And so one needs to remember to replace calcium, either chloride or as a gluconate. Now, what are some of your other intraoperative concerns? Very often, if there's a very distended bowel, the surgeon will start decompressing it, and that can cause either start decompressing it downwards, or they start decompressing it upwards and they ask you to suction out the Ryle's tube. And both of these are very messy, and that's why you need to use your syringe and you need to have a good suction available so that you can suction out the mouth and you can suction out the Ryle's tube. Now, if the surgery is prolonged, this is really can be quite a pain because their babies become hypothermic despite all your attempts at keeping them warm. And then you might require to ventilate them post-operatively because they're so cold and they have received so much of anesthesia, narcotics, and muscle relaxant. And you need to keep your eye out for when the surgeon gives a peritoneal wash, because sometimes you have junior people on the floor, new nurses. You need to make sure that the fluid is warm, it's not hot, and it's not cold. Because you don't want to cook the bowel, and you don't also want to cause excessive hypothermia. A brief word about neonatal laparoscopic surgery, which is certainly on the rise, and it's not an easy gamut for anesthesiologists. One of the biggest things is that you have no access or very little access to the baby, and for you to be able to evaluate. Very often the baby's head down, and that also splints the diaphragm. And it's so important that even before you induce and during the procedure, you constantly aspirate the Ryle's tube so that you don't have any distended stomach. Most pediatric surgeons are very cautious. They usually make an incision before they pass the trocar, but you might have some junior surgeons who might be a bit gung-ho, and you need to watch out that you don't perforate at this point. It's very important that as an anesthesiologist, you watch the pressures that are building up within the abdomen, and you want to make sure you need to watch how is it affecting both the respiration and the cardiovascular system. And this is where a cuff tube helps. Right. What I'd also like to stress is, remember that for the inflation of the abdomen, they need to have a well-relaxed anterior abdominal wall. And that's why these babies require good muscle relaxation. And sometimes we wonder why the surgeon keeps asking us. And the point is, you don't want them to be struggling, and you need to have a well-relaxed anterior abdominal wall. Now, what are some of the post-op concerns? One, if the child has had a gross distension, sometimes it's difficult to close the abdominal wall. If the child is having abdominal wall surgery, that also might be a problem. And what you're concerned about is high intra-abdominal pressures, which in turn affect perfusion to the lower limbs and also to the gut. And so you need to keep an eye on that. Is the child hypothermic despite all the trouble you've taken? Are you going to be able to extubate or not? This all depends on how sick the child was to start with, and how long the surgery was, etc. But in general, you should be able to extubate the baby if he's normothermic, he's breathing well, he's active, moving all four limbs, and is hemodynamically stable and is able to, is awake. And those would be your criteria for extubation. It's so important that you continue post-op pain management and continue IV fluids, and remember that they continue to lose fluid into the stomach, and you need to watch that they get enough fluids post-operatively as well. So in conclusion, I would say one of the most important take-home messages is that the anesthetic management of neonates requires expertise. It requires good communication between you and the surgeon. Remember, there are other congenital anomalies, and you need to be alerted to cardiac, Down syndrome, VACTERL, which is associated very often with gut anomalies. It's so crucial that you yourself as an anesthesiologist reassess for adequate hydration and know how to correct it. I have had situations where the child came into the OR really flaccid and very, very lethargic. And I just sat for about half an hour and pushed some volume in, and she just, woke up like a bright little flower. And only then we induced the baby. And it's so important for you to be aware of that, because if you induce a dehydrated child, you might lose this child with induction, and they may not even be able to proceed with surgery. It's so crucial that you titrate your anesthetic drugs, both inhalational and IV. And remember that these babies are very vulnerable to hypoxia, to hypotension, to hypothermia, and hypovolemia. So with that, I conclude that it is so satisfying when you've done a good job and you've adequately assessed these children and you've taken them through the stormy surgical period, and you can hand over this baby to the parent and the surgeon at the end of the day. Thank you very much.
Thanks a lot, Dr. Elsa, for that excellent talk. The minute details that you've gone into speaks volumes of yours and Dr. Rebecca's experience as pediatric anesthesiologist. And surely the students have learned a lot, and so have we from both of you from your lectures. Thanks a lot. There are several questions that have been asked by the audience to both of you. So we could just start asking some of them, if you don't mind. So since Elsa, you were the one who spoke the last one, this was the second talk, we could start with you. Somebody has asked, can we give injection thiopentone for induction? And what would be the least possible dilution that you would recommend?
Well, I didn't go more than 0.1. We had about 25 ml milligrams per ml. I wouldn't go less than 12.5. That would be my least dilution. And yes, you can use thiopentone. It is a great drug. I wouldn't say no just because you're not being old-fashioned. Yes. I think the only concern in this day and age would be that it has a prolonged duration of action compared to propofol. But actually, if you think in terms of rapid sequence, it is still a drug of choice.
Yeah, definitely.
I'm not sure if anybody else has any other comments on that.
I think it's difficult to get thiopentone.
Yeah. People are not buying it. It's not available. They're not diluting it. So I'm sure it is actually a good drug to have. It doesn't drop your pressure as much as the propofol does.
We've
True.
used it for years together.
That's
I know,
true,
but what to
very
do? It's
true.
like halothane. It's not available now.
Very true, I know. And the youngsters want all the new drugs all the time.
Yeah.
Because they only
Another
know the
question,
new drugs.
sorry?
They only know the new drugs. They do not
Yeah,
know.
they don't know exactly, I tell you. That's true. Someone wanted to know, why should we give a soda bicarb to the
Actually,
patient?
that only depends on, you don't normally give it. It's based on, how sick the baby is. If you've done a blood gas and you've got reports back that the child is definitely acidotic and, you're in the process of also rehydrating, that would be the only indication. Otherwise, bicarb is only indicated depending on the blood gas reports. I'm talking about a sick child who's had become dehydrated. Besides other tests, we've also done a arterial blood gas, and you've got the reports, and the child is acidotic, and you might have. That's the only time we would give.
Yeah.
Not empirically.
Yes, very true. Rebecca, somebody wanted to know whether you would like to use a cuff tube or an uncuffed tube for your babies with the clefts.
Jayashree, I've got a list of the questions that were asked, so we should go ahead and answer them.
Right. Yes, please do.
A cuffed endotracheal tube, I don't use it for clefts. Because for a cleft lip, we use a throat pack. For a cleft palate, the patient's position is such that blood tends to stay in the posterior nasopharynx. So if it's for obstruction of blood and secretion into the chest, we don't need it. And if you get an appropriate sized uncuffed tube, I think it's fair enough. And if you use a cuffed tube in a child, you have to be very careful about the amount of air you put into that cuff. And you have to keep assessing it, which is very difficult to do when the child is completely draped. So I personally do not use a cuffed endotracheal tube in these children. There was another question about echoes. Would you ask for an echocardiogram in patients? If I suspected a cardiac problem, or if the child was syndromic, I would definitely do an echo, because it's very difficult to make out murmurs in a child whose heart rate is going at 140, 150, 160. So an echocardiogram would be good. There was someone who asked how I would anesthetize these patients. I use sevoflurane air, atracurium, and fentanyl. Paracetamol in addition to fentanyl. In the small baby as a suppository. In the older child, I would use an intravenous paracetamol. The surgeon does use infiltration, and most babies do very well with that infiltration for the lip. The palate may have a little more pain. But on the whole, I do not use inferior orbital blocks, because the baby tends to then lose sensation over the face, and he doesn't know why he's lost sensation over the face, and he can't feel the mother's breast. It's much better if he is allowed to feed and he has some other form of pain relief. Monitoring, I'm very particular about EtCO2 and peak inspiratory pressures, because that will tell me when there's an obstruction or to the tube, or the tube has slipped out. Fluids to be used, I use Ringer lactate intra-op after having fed the child clear fluids 2 hours before, and it would be a dextrose containing fluid. In the smaller child, I add 1% dextrose to this Ringer lactate, and I make sure that it's given through a burette set or an infusion pump. Post-op pain relief, I continue with the paracetamol and feed them as early as I possibly can. Does that answer those questions?
And what about the hand ventilation? Sorry, did you answer that, Rebecca?
No, hand ventilation, I would have used it earlier. I'm sure Dr. Devekar would agree with me, use it earlier. But with hand ventilation, it's not as good as the peak inspiratory pressure on the machine, because it tells me a lot better than my hand. But if I don't have it, I would use my hand. Again, if I have the patient completely covered and I am standing at the foot end of the patient and I've got a long extension to my bag, it's very difficult to feel the nuances of the change in peak inspiratory pressure. So if I have a good machine, I would definitely go in for using the machine. If not, I use my hand.
True, true. Right. Elsa, one
Yes.
question for you. In the neonates especially, would you like a thyroid profile in them?
I don't usually ask for it routinely.
Yeah.
I don't usually, unless there's some specific thing in the maternal history. No, I wouldn't.
Right.
But there've been a lot of questions over here regarding fluids and also
Yes.
analgesia.
Yeah.
So very often, I mean, what one needs to very clearly know is there's a difference between resuscitation and maintenance. So you know that this baby is dehydrated and you've assessed whether it's mild, moderate, or severe. And the fluid that you give for resuscitation is normal saline. You don't give lactated ringers at that stage. You give normal saline. You usually build up the blood volume, make sure that there is some urine output. And once you know that the electrolytes have stabilized and that there's a urine output, for maintenance during surgery and for replacement with crystalloids, you give ringer, a balanced salt solution. That is what is recommended. Now, if the baby is, we've been talking about infants, I would usually add 2 ringer lactate, either a 1 or a 2% of dextrose as well. And I would also be monitoring the dextrose. Some centers in the US, after the neonatal period, they don't give routine dextrose. They would just give ringer lactate and if required, replace. So you need to be clear that for intra-op, you don't give saline, you give a balanced salt solution. Your presumption being is that you've hydrated the child with saline. That answers that. Now, generally, NSAIDs are not recommended in children less than 3 to 6 months. So the drug of choice is paracetamol. You can give it IV. I think now it's not really recommended. Most of the rectal preparations are avoided because of legal implications. So you have IV paracetamol, give that. And if the child is older, more than 6 months old, maybe then you can go ahead with ibuprofen. That's what my opinion is. Rebecca or Dr. Sood, any other opinions on that?
I would agree with that. I was just looking at some of the questions. Madhusudan Upadhyay has asked, would your tubes with micro cuff be okay? My take on this is it necessary? Because one, it's very much more expensive. Two, I don't have access to the pilot balloon, which I will need to check my pressures. So I would just use a regular RAE southbound tube. The Oxford tube, another question said we used Oxford tubes, but the Oxford tube, the connector comes right at the lip. So it's very difficult for the surgeon to put in a gag and then for us to access it if it disconnects. So I would prefer the RAE. I think it was a great change that we got the RAE South Pole. Microcuff, I would use if my child was going to the ICU, if the child was having a laparoscopy and there were pressures which I was worried about. Definitely there's a place for microcuff tube, but I don't think for cleft lip and palate, microcuff is necessary.
The pack is there.
If you have it, fine.
Yeah, I mean, for abdominal surgery, I think there is certainly a role. But I think that the main rider I would want people to take home is that if you're using a cuffed tube, you have to continuously monitor cuff pressures. Can't be intermittent. because you need to make sure that your cuff pressures are always less than what is recommended. So
Absolutely.
that then at least you have some, legally you have a standpoint to go by.
Right.
The thing
And-
is, we don't immediately see the problems with the cuffed tubes. We don't see immediately what harm we have caused with the cuffed tube. Very often, those are babies who have been intubated in NICU who come to us later with tracheal stenosis. And this is partly because we thought that cuff tubes were always safe. So there are riders. We have to be careful when you use it.
I think we are, of course, having a whole lot of questions. Another one that has just come is, what about steroids? Elsa, would you like to use steroids in the neonate preterm children, babies, intraoperatively?
I'm not really sure. I've not used it routinely unless actually the neonatologist has particularly indicated it. I wouldn't use it. I mean, to what? Avoid a problem with the trachea or prolonged intubation, or what would, I don't know what the indication would be for this.
Probably, I think, just because it's a neonate, maybe. I'm not really sure.
I would never give routine. No.
There's no
Well,
need.
there are a lot of questions here about ketamine. Of course, I mean, there's no one way of anesthetizing a baby. You can use combinations of different things depending on what you have available, what you are comfortable with. But I just think you need to ensure that you give an anesthetic. You don't just give oxygen, you need to give an anesthetic. And it's so important that you do give an anesthetic and you do provide enough analgesia, and that you're giving, and that this child should not bear the brunt of you. And one of the problems if your child is hypovolemic is that you turn everything else off. So you need to, at that stage, as I said, then you go high on your opioids and maybe add some midazolam as well, and that child would then require intubation. I think if there are any more questions, they can put it in the chat, and Rebecca and I can answer them.
Yeah. Right.
Just one question, which is where they talk of the role of ketamine in induction. You would use ketamine if the BP were low, but remember, ketamine has a longer action. And if cleft lip and palate, if it's cleft lip, it's a very short procedure. So you're going to have a very drowsy child at the end. So use it if you really need it. Otherwise, I wouldn't use ketamine to induce.
I also agree with Rebecca on this point.
Yeah, the other questions of can scoline be used? The answer is yes. The other point is, there was another question here on would you use plasma light? Now, I think generally, after all the hoo-ha about synthetic colloids, it's come full circle. And most of the time now they say just go in for crystalloids or blood. I think that's what I would certainly prefer to use in a baby. Crystalloids or blood, even albumin, people are going away from that. So if your child needs volume, you give either packed cells or platelet-rich plasma as and when required. I think we've shot our time.
So, right. I think, yes.
Sum up now?
Yes, ma'am.
Yeah. I think I would like to mention that you people, you youngsters, if they are there, that this is you are in the golden age of anesthesia today. We are coming from the Stone Age, so you can imagine what it must have been only to have inhalation agents for babies, and also the abdominal surgeries and things we did, and the relaxants were not. Nobody touched relaxants for babies. You can imagine how it was. Now, of course, it's such a interesting and, as I say, a golden age for anesthesia. I think, shall we now sum this up?
Yes, I think so, ma'am.
Yes.
And we could probably conclude this session, and we could go on to the next one. Thank you very much, ma'am, Rebecca and Elsa. Thanks a lot.
Thank you.
Nice having met all of you.
Sir, madam.
Yes, same here.
Divekar madam and Jayashree madam. Nasser sir. Sir, if you're audible, please.
Sir is not audible. Anyway, thank you both the faculties, speakers and chairpersons. So nice of you for sparing your time and being with us. Really wonderful, and all the seniors are there among the audience in this today. Shall we go to the next chairpersons and?
Yes, sir. We will move on to the next session, sir.
I request Dr. Gupta can session. Please.
Okay. Manjushri madam and
person you can second.
Please take over.
Manjushri madam, please. Manjushri madam is the principal of Calcutta National Medical College and past national president, and Dr. Sunanda Gupta, past president of AOA and professor and head of Geetanjali Medical College, Udaipur. Sunanda madam and Manjushri madam, please. Manjushri madam, please unmute. Please unmute, madam, please.
Unmute. Can't hear.
You have not unmuted. You are a co-host.
Ma'am, I have sent a request. Manjushri ma'am, I have sent a request. Click on that.
Is not able to unmute.
There will be one mic, Manju. Manju, there is one mic. Just unmute that. Just click on that mic. No, at your place, there is a mic.
Madam, Sunanda madam is also joined. Please unmute Sunanda madam. Madam can talk then.
You're still not unmuted.
Yes.
Sunanda, you can talk.
Okay. Good evening, everyone. And it's a pleasure to be included in this elite band of lady anesthesiologists, which is headed and tailed by our male counterparts. So today we are going to have our first lecture in this session by Dr. Is it Manimala Rao or is she, who is going to speak first?
I think it's me.
Indrani madam speak first, madam, then followed by Manimala madam.
Okay, Indrani. So a good friend, a strict administrator, a true academician, and a favorite.
Ma'am, unmute, ma'am. Sunanda, ma'am, unmute. Yes, ma'am.
Okay. She's a fine dancer and never smiling HOD of State GS Medical College. And she has had joined Pennsylvania as a Hargobind Fellowship for cardiac anesthesia. And so today she's going to talk about a difficult topic, failed regional anesthesia, and then how to intubate a difficult airway. So I think this is one of the most difficult topics, Indrani, and I know you do full justice to it. So here we are going to listen to Indrani now.
Thank you so much for this, for the great introduction, ma'am. As you rightly said, it's a very practical problem which any of us can face in our practice. So, respected eminent chairpersons, Dr. Manjushri Ray, Dr. Sunanda Gupta, and my dear friends, it's my proud privilege to be part of this all-women CME under the aegis of ISA Kerala State Chapter. Thank you, Dr. Giri, Dr. Nazar, and Dr. Medel for this opportunity. So the topic, as I said, is anesthetizing a patient of a difficult airway patient in whom a regional anesthesia whom you have given us your own rescue has failed. Now, what do you have to do? Now, I would like to start this lecture with this great wisdom from Dr. Martin, who said, the obligation to guarantee airway control is obviated by spinal, epidural, or other regional techniques. So the entire lecture is a sum of this. So let us look into one of the first cases where I'm looking at a patient, a 28-year-old primey with morbid obesity and a short neck, who's presenting here for a lower segment cesarean section. She's Mallampati grade 4. She has got macroglossia. She has severe preeclampsia, and but her coagulation is normal. So you're thankful, and then she's been for the section for a deep transverse arrest. So you manage to get a long needle, and then you poke her, multiple attempts of spinal, and finally you succeed, and you give about 2.2 ml of sensor care. After 20 minutes, you find that the block is inadequate. Very many times we find, not just in a difficult airway, even a normal airway patient, where the block is inadequate. So what do you want to do now? Here is a case of difficult airway. Do you want to wait longer? Do you want to repeat the spinal? Or you want to give combined spinal epidural? Even if you decide to repeat this regional, you've already attempted so many times. What dose you want to give? Or do you want to take the challenge of general anesthesia? Now, what are the choices? As I said, repeating the spinal anesthesia. So the same dose may provide a good block, but then you have a threat of a high spinal or a total spinal is there, isn't it? So if you're giving a lower dose, there is a threat of an inadequate block. And you also know that it's technically a difficult problem in these patients, and long needles are generally not available in most theaters. And if you're looking at general anesthesia, you know here is a patient sitting in front of you, obese, short neck, thick tongue, and with lower margin of safety, threshold of oxygenation. So this patient is not just difficult mask ventilation, difficult intubation, anatomically and physiologically a difficult airway. So you're wondering, should I still proceed with general anesthesia, or will it get messy? Should I get away with a repeat spine? You're confused. What am I supposed to do now? Now, what would I do? So I would like to revive the same block with a head low position or a left lateral position with head down, a limited hip flexion or a Valsalva maneuver or a cough. Ask the patient to cough. And you know that this block is going to be technically difficult. So all these are called revival maneuvers. So you're going to try revival maneuvers. And then all this you're going to try over the next 10 minutes. So you've already lost 20 minutes, now in more 10 minutes. And then if it still is not patchy, if it has still not come up the level, then you would want to give a repeat spinal. So my choice would be, I would like to give because the level is already T12L1, my choice would be to give 1.2 cc of injection sensorcaine as the block was up to T12L1. If the block was totally absent, then I would repeat a full dose of injection sensorcaine heavy in this patient. So in all this, when I'm trying this, I would keep a difficult airway trolley ready and an expert help standby. I would ask my friend from another theater, please come and hang on with me over here. A successful regional anesthesia may help avoid the need to directly manage the difficult airway, but it does not always prevent it. Now look at the second scenario. The cesarean section has started now. You have a difficult airway patient. Here is a patient with kyphoscoliosis, and you've started the case. The surgeon has taken an incision. It is a patchy block, okay, and the patient is complaining of pain now. Now what do you do? So here you know that it is a case of anticipated difficult intubation. You knew it from all the way before. Okay, so you need to keep your difficult intubation trolley, the entire armamentarium of difficult airway using a Macintosh, McCoy, polio, laryngoscope, Cook's catheter, second generation, LMAs, cricothyrotomy set, etc., and an expert help. You will keep all of them ready. Give H2 receptor antagonist, reoxygenate this patient for about full 3 to 5 minutes so that you can increase the apnea time. Give a right uterine displacement, a ramp position to optimize intubation. If HFNC is available, start with the HFNC because it gives you a CPAP and it gives you a longer apnea time. And induction, you would give with injection propofol, check with bag mask ventilation. If cricoid pressure is impeding the ventilation, you can relax that a little bit and intubate and proceed with the surgery. Now, you have tried intubation, now it is unsuccessful. Now, what will you do? You will re-attempt the intubation by optimizing the patient, position, change of device, and things like that. And you have a ramp position, external laryngeal manipulation. You will ask your friend to help you. If you're unsuccessful, deepen the anesthesia, try all these maneuvers. You can use the various equipments, video laryngoscope, as I said, and third attempt will be by an experienced helper when you're having it by the side. And you have to declare a failed intubation here. And now, priority now is to maintain oxygenation. Consider an IV anesthetic to prevent awareness. So 2-person face mask technique with oral and a nasopharyngeal, oral nasopharyngeal airway and gentle mask ventilation in between attempts is advised. You try a second generation LMA. And if there is a problem, you can slightly remove the cricoid pressure at this point of moment and try a maximum of 2 attempts. If the LMA is successful, proceed with the surgery, put in a draining tube and consider the merits of having the patient on spontaneous or a controlled ventilation. If you have used an intubating LMA, you can try intubating through the LMA. But supposing you have failed the LMA, but you are able to bag mask ventilate the patient. Now, here, because the surgeon has already he has taken the incision, you have to consider a TIVA. So you can give propofol or ketamine or ketamine propofol combination because it does not cause uterine atony, and in the meanwhile you have to maintain the cricoid pressure. Imagine, so you have the ventilation perfusion mismatch and the pulmonary compliance may actually improve after delivery. Many times, as soon as the baby is out, if you're trying to actually put in an LMA or put in a tube, many times it becomes successful at this point of time. Now, supposing if you are unsuccessful with your bag mask ventilation and your intubation or your LMA attempts, now that could happen because of wide variety of reasons. Patient can have laryngeal spasm or edema, stridor, or because of poor chest wall compliance. You now at this point of time use a neuromuscular blocker, and then this is for prevention of laryngospasm and reduce the airway pressures and gastric inflation and surgery by reducing the abdominal muscular tone and chest wall compliance. In the meanwhile, send a call for the ENT surgeon and intensivist. So if you are unable to bag mask ventilate this patient, even after giving a relaxant, you need to have a front of neck access. If all this fails, anesthesia is maintained with a volatile agent, sevoflurane, and inform the neonatologist about difficult intubation at this point of time after the front of neck access. So the IDA has come out with an excellent algorithm for a difficult airway in an obstetric patient. So it is just a repeat of all the sequence which I just said, So you have to try maximum 3 attempts to intubation, and then you can change the device, change the technique, change the operator, call for help, then try the second generation SAD, and then if that is also not possible, then maintain the depth of anesthesia. Then you have to have a rescue face mask ventilation. And once you are able to do, if possible, if it is not an emergent section, you can awaken the patient. Otherwise, you have to give a muscle relaxant and then try oxygenating the patient, try to bag mask ventilate the patient, and even that is not possible. There is failed oxygenation and failed ventilation at this point of time. You need to go for a front of neck access. And if the patient has a cardiac arrest, you have to have a perimortem cesarean delivery immediately and then try all over again. So here is a beautiful algorithm which I just mentioned. So if the patient, if you have failed, and if the skin incision is, if it is 30 minutes before the skin incision, you can repeat the spinal. But if it is less than 30 minutes of skin incision, you will try all the reviving maneuvers. But if the skin incision is already taken, and if it is less than 30 minutes and there is no way that you find any block, please, you have to go for a recourse of general anesthesia. You have to go with all the precautions of a difficult airway or an awake fiber optic intubation. So one of the surgeries which are appropriate for a regional anesthesia alone is cesarean section. So that's a savior. But there are some surgeries that may require preoperative airway management and general anesthesia. Those are the surgeries where patients may have major blood loss, such as major trauma, or long surgeries, or patients in whom patients are prone, or if the patient, if the regional block may not actually cover the entire area. So these are the patients in whom you have to go for a general anesthesia. So use of regional anesthesia in a patient with a recognized difficult airway will not solve the problem of the difficult airway because it is still there. So what are the major concerns of regional anesthesia in a known case of difficult airway? So what if the regional anesthesia fails, or if the effect is partial or incomplete? What if there is a high or a total spinal anesthesia? Am I ready for a general anesthesia for this patient? What if there is a sudden deterioration of the patient's condition during surgery? Okay, you have given regional anesthesia, repeated the regional anesthesia, but patient can have blood loss, hypotension, hypothermia, myocardial ischemia, laryngospasm, bronchospasm, anaphylaxis, transfusion reaction, anything and everything where only endotracheal intubation is required in this patient. So actually, what if there is a toxicity of local anesthetic? And what if there is an unforeseen or an accidental prolongation of the surgery? So these are the concerns you have in your mind in this case of a difficult airway when you have given regional anesthesia. So what has to be done? So you have evaluated the patient, you have recognized a difficult airway. So determine if the surgery and the patient are appropriate for regional anesthesia now. So if you feel that the surgery can be terminated quickly, you can proceed with the regional anesthesia. And if the regional anesthesia fails in an elective situation, you can cancel the case. Or if you feel that it's a semi-emergent situation, then, or if it is an emergency situation or regional anesthesia unacceptable, you have to go for general anesthesia. So this is the same thing. So you will cancel the case if it is non-emergent, or if the preparation for a difficult airway is inadequate, or if you don't have expert help. And if it is a semi-emergency or an emergency, you will redo your spinal or a USG guided block or combined spinal epidural, and provided you have a difficult airway cart available. At this point of time, I would think that a combined spinal epidural would be more handy with me and more comfortable then a spinal anesthesia if it is possible. Sometimes you try a combined spinal epidural in this patient, and to your bad luck, you find that there is a spinal intrathecal puncture. There are many people who will have a continuous spinal anesthesia in these patients. So again, it is up to the anesthetist confidence if you want to continue with the continuous spinal anesthesia, because it generally you need a lesser quantity, but then the only problem is about PDPH and cauda equina syndrome. That definitely that problem is in your head. And any other patient, you will have to give general anesthesia. So who are the ones you have no choice but to give general anesthesia? They are the ones who have a complete regional anesthesia failure or partial failure, in whom cancellation or redo regional is not an option. High or total spinal anesthesia, sudden deterioration of patient's condition during surgery, local anesthetic toxicity, or unforeseen or accidental prolongation of surgery. In these patients, the gold standard will be to use an awake fiber optic intubation if the situation allows. So this is a fantastic algorithm given by the ASA, American Association. So they said that if you have to give a repeat regional, you have to pass a PASS checklist. So what is a PASS checklist? PASS checklist is whether the patient, look at the PA stands for patient. Then S is for surgery and S is for surgeon. So the patient, is there an absence of any absolute contraindication to regional anesthesia? Patient approval is there and the clinical stability is there? Yes. Surgery, duration of surgery is less than the duration of the regional anesthesia you're putting in. And with the blood loss is less and the possibility of airway access is there with you. Yes, then you go ahead. Surgeon, is the surgeon dependable and reliable? And if the surgeon, is he capable of doing local infiltration in case there is any patchy block or something like that? If the answer is yes, go ahead with the ultrasound guided regional anesthesia. Again, the operator's expertise definitely counts, because nowadays ultrasound has become a fundamental tool to help finalize any anesthetic plan. So it's become mandatory for all of us to learn ultrasound. So you have to have a good ultrasound assessment of the patient before proceeding with regional anesthesia in this patient. And if the answer is no to all of this, please go ahead with the airway management with awake intubation. So the team should be briefed with the plan and what you want to do. You have to have a good line. Anesthesia and emergency drugs should be drawn up on these patients, and you also should have a working defibrillator. And the checklist of equipments for difficult intubation, trolley like mask, cannulas, laryngoscopes, all kinds of laryngoscopes, all sizes of endotracheal tubes, stylets, jelly, suction equipment, gum elastic bougie, SGAs, ramping pillows, monitoring equipment, including capnography, HFNO for oxygenation, fiber optic bronchoscope, especially a small diameter fiber optic bronchoscope, video laryngoscopes, second generation LMAs, intubating LMA, airway exchangers, and all your drugs, cricothyrotomy set, all of them should be available with you. So let's look into another case. There's a plethora of problems. So you have a patient with TM joint ankylosis coming for appendicitis, for an emergency appendicitis. How are you going to manage the case? So are you going to give spinal anesthesia, or you want to give combined spinal, or you want to give GA? So here, the anesthetic skill for a fiber optic bronchoscopy is very important. Remember, if there is a problem with your regional anesthesia, then you have to know how to use a fiber optic bronchoscope. Again, the surgical skill also counts. You should have a fast, skillful surgeon to do the case. So spinal or combined spinal anesthesia can be used, and fiber optic bronchoscope if regional fails. Now let's look into another case, a case with the trauma, fracture humerus. It's a difficult airway case and you're doing it under brachial plexus block. And 20 minutes afterwards, the patient is complaining of pain. Now the patient is having a lateral position with a humeral rest, such an awkward position for you to even think of looking at the airway. Forget about even in a normal airway, it is difficult. And here is a difficult airway for a patient. So insertion of laryngoscope is just impossible. Mask ventilation in a lateral position in this patient with a humeral rest, again, very difficult. What is to be done in this patient? So remember, a repeat block is ruled out because you've given a full dose. However, if you have used an ultrasound guided block, you can repeat another ultrasound guided block in this patient. And GA, after making the patient supine with full preparation, as I already said, a second generation LMA or a Boji guided intubation or a radiolaryngoscope guided intubation or a FOB guided intubation, any of these are possible in this case, and you can, and so that you can ventilate and oxygenate the patient well in this patient. Now coming to another very, very difficult case, it's a difficult regional anesthesia, difficult general anesthesia. This becomes an anesthetist dilemma. So here is a case of ankylosing spondylitis. It's got an unusual combination of rigidity of fusion of the spine with focal cervical osteophytosis. Now, as the cervical spine involvement progresses, there is a decrease in the extension and the patient can progress to a chin on chest deformity. There is a low threshold to convert to general anesthesia if regional anesthesia fails. If there is difficult mask intubation, difficult front of neck access. So even if RA is re-attempted, it is with the best and the skilled assistant, it's going to be a problem. So in these patients, airway blocks are performed before attempting any regional technique. Because in a catastrophe, in an emergency, you are not going to work at your best. So the patient should be psychologically aware and cooperative. So you first perform the block in these patients before you can even try anything. And the choice is limited to a fiber optic bronchoscopic intubation with no sedation in these patients. So another case we've seen many times, a thyroid swelling coming, say, for a perianal abscess drainage. Are you going to give TIVA a huge thyroid swelling? So generally we give TIVA in these patients, but here TIVA is never an option. Spinal anesthesia you've given and it has failed. Now what? Now you will definitely try the reviving maneuver, which I already said, head low, left lateral, head down, Valsalva, you will do everything. There is a worry of compression and deviation of the trachea because the patient can have tracheomalacia. So if you're thinking of giving a repeat spinal, remember if it is a high spinal, you are never going to be able to ventilate or intubate the patient. Here, even your supraglottic airway is not going to help. And your airway will be lost with a huge thyroid. Phona is impossible. And you cannot sedate the patient. So again, try repeat spinal only after preparing the airway. Here is again another case where you prepare the airway first before attempting the next spine, before attempting a regional anesthesia. So to summarize, before considering regional anesthesia in a patient of difficult airway, an anesthesiologist should have a pre-formulated strategy for intubation. Every anesthesiologist must know multiple approaches and techniques for management and also understand the limitations of the various techniques. Regional anesthesia as the primary anesthesia technique is acceptable only if it is practically comfortable with his or own ability. So know your own limitations to secure the airway, or if local infiltration anesthesia is an option. And sedation should be preferably avoided in all these cases. Patient selection is very crucial in these patients. And if you have a doubt, please choose general anesthesia in this patient. It is recommended that a plan for general anesthesia is prepared for every patient with an anticipated difficult airway, appropriate equipment, clinician, staff, technician, and a good hand to help you should be available whenever you're handling a difficult airway patient. Remember, intubation is not the end of story. Here is a patient where extubation is also a major problem in such patients. So friends, if you have a patient with a difficult airway in where regional anesthesia has failed, better be safe than sorry. Thank you very much.
Thank you so much, Indrani. And that was a very lucid description of how best to go about with a difficult airway and a difficult back. And you showed us how best to do it with different case reports. And you have also stressed on how important the pre-anesthetic evaluation is, because most of the time our residents forget that cesarean sections, we are going to do it under regional anesthesia. So they forget to look at the airway, and an unexpected difficult airway is the worst scenario that you can face. So we'll be taking your questions after this session is over. And now I hand over to Manjushri for introducing Manimala. Is Manjushri there?
Madam, Manjushri madam's audio is not working. She called me just now. I asked to log in again. She will try again logging in. Yeah.
Okay, so we have Manimala here, and Manimala is a great friend of mine, ever smiling. And after doing her undergraduation from Osmania, she went to London to do her diploma in anesthesia. She did her post-graduation from All India Institute of Medical Sciences. She has many awards under her belt. And one of the important awards, I think, is that NBE award, which you got for being the best teacher. And her special interest is cardiac and critical care. She's a lovely, warm friend, always smiling. So here is Manimala Rao. She's going to give you tips on how best to manage a burnout syndrome, and especially during the pandemic. We all need those tips, Manimala. So here, please start.
Yeah. Thank you, Sunanda. As usual, it was nice seeing all the ladies from our time, and particularly Madam Divekar, who was a great inspiration to all of us from those days. Well, I was wondering, because in the anesthesia from the ISA Kerala branch, they have chosen all women, and most of them were the anesthesia topics. And then Venkatgiri asked me to talk on the burnout of anesthesiologists and the critical care people. Can I have the slides, please? So, literally speaking, when you say burnout, what is really burnout? Yeah, I can't talk without the slides.
Shilpa, please start the slides.
What happened to your slides?
Shilpa.
Okay, sir. Okay.
Okay.
Okay. So, video is there. You have to start. Okay, I can talk, but it will be nice if the slides are on. So the burnout, the first slide is, there are a lot of, fire, and then there are embers.
Ma'am, you can see the slides, right? So,
Is she on mute?
Ma'am, are you there? Venkatagiri sir, as I have shared the screen, I am not able to see the participants.
Manivala madam, slides are ready, madam.
Has she lost the connection?
Madam is not there.
I think she has to log in again. Okay, please unmute Manjushri madam also. She has just joined, Manjushri madam, and make her co-host, Manjushri madam. She joined.
Madam, please unmute Manjushri madam. Yeah. Madam, please talk. Now it's unmuted.
Hello. Good evening,
It's audible.
everybody. And it's a great pleasure to meet you all, especially so many senior anesthesiologists, and for which I'm really thankful to ISA Kerala branch, especially Dr. Venkat Giri. And I could learn so many things, but unable to unmute me. That's why I was not able to communicate previously. But in my absence, Sunanda madam has steered the entire thing very nicely. So please, madam, continue. Yeah.
No, the talk is yet to start, madam.
Manimala madam.
Find where Manimala is.
No, madam is there. Madam, please unmute and talk. Manimala madam. Manimala madam.
Doing that.
Yeah.
Well, look, 1 second. Yeah, this is regarding the burnout. Can you hear me?
Yes, ma'am, you are audible.
Okay. So the burnout shows what exactly, is it a fire or is it an ember? So if you can find out at the fire, you're better than if you find out at the embers. Okay, next slide.
Ma'am, you there? Hello, ma'am, you there?
Madam is there. Please unmute, madam. Madam is not co-host now.
Yeah, that's better. Thank you.
Audible, madam, please.
Yeah. Okay. So what is really burnout? It is usually a chronic work stress. This problem has grown over the decades and absolutely has no correct definition. But usually they say that it is due to a chronic work stress. Next. I don't know. You have to go for the next one. I don't know who is.
Silpa, next slide.
Ask her to change the slide. Or give it to me. I'll do it. Got it. So what is really, so the moment I finish, Shilpa, kindly change the slide. Okay. So it was
I'm
fine
sure.
about.
Yeah, I'm sure.
Yeah.
I will check it. The thing is,
Yeah,
it
please.
will take 10 seconds because as it has.
Doesn't matter. Doesn't matter.
That's
No,
it.
let us
Yeah.
not argue.
Yeah.
Let us do this. It was coined about 25 years back in USA by Hudenberger and Maslach, somewhere in 1981. So it is more than 25 years now. And it occurs in all the healthcare workers, teachers, and dentists who are very much in with the public. As a result of chronic work stress, it is happening even in the IT community now. Is a burnout syndrome is a disease of the modern society now. Next. taking more than 10 seconds. Please change. Yeah. So you've gone. Can you go to the other one? Next slide, please. Yeah. So what are the types you know are one is pragmatic, under challenged, and worn out. So these are the three varieties of burnout, which people usually call that. Next slide, please. So how do they describe the, if you are really burned out, how do people talk about it? One, they'll say, I am very much under stress. That's a very common thing to say, but you may not be burnout. My battery is flat. I like to pack it in and say goodbye to all these things. I'm completely burned out. So these are the various ways they talk about burnout. Next slide. So what are the signs that you can get to know that there is some burnout happening? Sometimes you feel very fatigued almost every day. You just don't feel like going to work. You feel listless. You don't like talking to many people, loss of appetite, and sometimes your memory, or insomnia, because that is one of the common things when you get a burnout. But that is also sign of the burnout can lead to psychiatric problems. So we have to find out whenever it is this thing. And there is decreased immunity. Sometimes we get a lot of, infections. And there you don't have a concentration and attention. Next slide, please. So these are the signs, symptoms which we have. And then signs of cynicism, that is, you are become very cynical. You say that I just don't feel like going to work. We all do that on Monday, when you have a holiday or you go there. Sometimes you feel about today we have to go to work. The loss of interest in work, and you really don't enjoy it. And some sort of a detachment, and even small things make you get irritated. Then sometimes everything looks negative, and then there is not much of a productive work you are doing. Next. Next. Yeah. So suppose you are wanting to know whether you are happy or whether you are a little bit cynical, you can always say, is the glass half empty or half full? So that's why how you look at life too. If you keep on thinking this glass is half empty, then only the negative thoughts will be coming on to you. Next. Next slide, please. I don't know what's the problem. So the burnout really, if you look at it, it is an interaction between the society and the working environment. So the society and the individualization. So these are the three things: the individual, the interaction of the society, and the individual, how he or she is working out. Next slide, please. The society and the work environment. So these two things you have to sort of combine. The individualization, loss of traditional support. Nowadays, you don't have, it's a nuclear families. So the traditional support is not there. The anonymity, when you are nobody, or sometimes you feel that nothing much is happening. Okay. Educational expertise and lack of time and multiple stress factors can be there at work or at home. Then in the work environment, there is a lot of mechanization. You have to continuously learn new things and become better and better. And work complexity, there is new thing now that all of us have learned ultrasound. So when we were the younger days, we didn't have anything except a red rubber tube and a Megill's laryngoscope. That is our thing. At the most, we may get a stillet. So these are the things which you find that you have to learn more things, and then specialization. So for all this, and what is your economical, psychological, and what is the psychometric mental factors? So these are all the things which you are going to be affected. Next. Just a second. Okay. So, I mean, I can't see all my slide, everything else. Yeah. So why does it happen? There is too much work, too little resources. Sometimes you have a lot of work, but your resource is so little. I can remember when I went to Nizam's Institute, there were 4 or 5 theaters. I had only 2 laryngoscopes. Every day we had to shift one from here to the other to the third theater in that way. But when I left, it was a different thing. But I'm saying these little resources sometimes make you very, very, unhappy, and that unhappiness goes. And sometimes you have no feeling or no control over one's work. It goes on, and somebody is telling you what to do, and things are not there. So these are the various things which can happen. And if there is no recognition of your good work and over demanding expectation, all these things, lack of sleep, no relaxation, all this will lead on to a little bit of burnout from all of us at some time or other. Next. So what is the stress and what is burnout? There are a little bit of differences. In stress, we are over engaged. There is urgently want to do, and we are hyperactive, and some amount of loss of energy, and then it leads on to anxiety. In the burnout, you are not engaged, you are disengaged, you feel helpless and hopeless, and loss of motivation and loss of ideas. So these are some of the things. Even if you are an idealistic person, you are not able to do it in that way, and which is happening with all so many nowadays, not in at least in the earlier days. These are the problems which people face it. Next. So in burnout, many times we all like to do hard work, and we should be recognized. Sometimes we will neglect our personal needs, like your exercise or a good food or some rest. So these are all the things. And the revision of values, denial of emerging policies, withdrawal, and you sometimes isolate themselves. And there are behavioral changes. And this is last is the depersonalization. You become somebody else, not yourself. And that leads to depression, burnout, physically, emotionally, and mentally. You are drained. Next, please. So there was an index by Maslach that is to be a gold standard, and they find out the various, they check up whether you have all these things, and then they will try to say whether you have a burnout or not. So one is emotional exhaustion, depersonalization, and low sense of personal achievement. So these are the 3 things which they will look at and then say, okay, there could be a burnout, and the index can be given. Next. So in the United States, in somewhere between 2013 to 15, they have done a lot of work on the physicians who showed that there were a lot of burnout. There are a number of people who have shown almost people like, according to our survey, their survey, the dermatologists, psychiatrists, and pathologists, they had least burnout and more burnout in the critical care, in the anesthesia, and things like that. Next. So they all gave, next. So they all gave this sort of this is all there in Medscape, so I don't want to go and tell you. But why do we have the burnout, and what are the various factors? One is the too many bureaucratic tasks you have to do, especially if you are a head of the department or you are assisting them, then there are too many. Some VIP culture. There are a lot of VIPs, and they take your, lot of your time and energy. So too many difficult patients. So you have, like they have all shown, suppose if you get lot of difficult patients in a 2 or 3 days, naturally it becomes a little more stressful for us. So various things can cause you this sort of a, and there will be difficult employees too, because all of us are not straight people. Sometimes you don't tell or you don't express your feelings, then you keep it in yourself and then you can only talk at the back, then nobody will know what you really require. So all these sort of people are also all around. You have to manage so many people. Next. So this is all about, these are the various things which have described how the burnout is and how the people who are dermatology or psychiatry, and these are the people who can give a better happiness. Even the radiologists have shown they have less happiness. Next slide. Next slide. Yeah, you go back. Okay. One more slide. Yeah, so these are all the physicians, even in emergency medicine, family medicine, all these people, ophthalmologists and dermatologists, they have shown to be happy in their work. Okay, might have changed now in 2020, but this was somewhere up to 2016 and all. But later on also seen anesthesia used to be a little higher, but now anesthesia is not that bad as compared to even critical care and all that. But the frontline people, they do get emergency medicine, such things, they are really stressed. Next. So these are the various causes I already said. So usually they give 1 to 7 as their this thing, and all the causes, too many bureaucratic, too much on the economy front, and employees, what is their problem? All these things also lead to difficult cases. They lead. Next. So these are all the stressors. So you have got a big cloud, and there are so many stressors from patients to our doctors and the work and the hospital and your boss. Everybody can be a stressor for you. Next. So, and also a time frame. So these two are saying that we lived a longer time in that, not that I say that I'm burnt out. I'm not. So you have to finally find out how you can get over these things in a time frame. The doctors can get stressed as we are doing more and more work. Yes, next slide. So next slide, it's okay. This is what I have already told. Next slide, please. So how do we cope? So one thing is, try and have a little nourish your creative side. Take a break from technology. Talk to the patients. Many times just don't go and you say, okay, you have got this, and you come away. Talk to the patient. Be more compassionate. And have some employees assistance program. Find out whether they really require. Then problem-based coping and appraisal-based coping. These two can be done. So if they have got a problem, as a HOD or a head of the department, you should be knowing what's happening in the department, and social support. And we have to have a different way of coping with each and every one of our employee. You should be knowing how they are doing. There should not be any, one over the other. You should not be talking about that. So you should find out what's exactly happening. Next. So so how do you really prevent workload, work life, control, reward, fairness, and values? Then for all these, you have to have a really good team. You have to meet at least once a week. You have to have some departmental meeting once in a month. Healthy eating habits, exercise is very, very important, and also sleep and learn to manage stress. So these are the various methods how we can cope. Next slide. So what about there was a little bit of survey. So when the anesthetists, they were all sent survey. So what did they strongly or mildly agree? They all agree that there is a high standard of practice that all of us say in anesthesia. Then practical aspects of the job, they're happy because you're doing something all the time, and that gives you immediate result, provide relief and pain in suffering, and clear-cut responsibility is there, and able to sign off at the end of the day. So we don't carry everything home unless we had a bad case, which is rather rare, because you all remember in 50s or 60s, there used to be 1 in 1500 mortality due to anesthesia. Now there is 1 in 200,000. So we do not usually, that's why I tell many surgeons, you can operate, nothing will happen under anesthesia, we'll take care. So that is what the magic of anesthesia. Some people felt that it is magical. Okay. So how do your colleagues react to stress? So most of the, if you have got a good experienced assistants, you can be better. So that is the technician or a nurse or somebody who is trained, and develop a group cohesion. Then prioritize home and work commitments. Find ways to control your life, improve funding. So we have to have a departmental fund and work towards that. Avoid solo practice group, then it will be more stressful. Next slide, please. So in anesthesiology, it is a stressful specialty, no doubt on that. Even though we have lot of monitor, we are the best monitors. That every one of you agree. And most people will develop mechanisms to cope. Sometimes the inexperienced trainees sometimes feel very, worried about this anesthesia in the beginning. So you have to really nurture them in the beginning. The male gender get a little more irritated. It is not my saying, it is all published in a journal. So male gender, female also are stressed, but sometimes they feel a sense of accomplishment because they are working, they're doing a good job, and they feel. And the family relationship, sometimes they are soaring because of their work. Next slide. Yeah. So we all understand 4 P's and 1 A, that is physics, physiology, physician thinking and knowledge, pharmacology, and anesthesia technology, administrative skills, and everything, which is includes most important is communication. So many times people think if I take anesthesia, I don't have to communicate. You are totally wrong. If you are not communicating, you will find it more stressful. So always try to communicate, because you have to communicate with a lot of people. Proper, physical fitness, peer support, and proper rest is also required. So if you have some creative activity, these burnouts are there in American, Australian, Polish, and 40% in Finland, Austria, Chinese. Everywhere there is burnout in anesthesia. This is anesthesia. Next. So how are they coping? One, you have to have a sound knowledge, a good communication, academic bent of mind, and you can do so many other things like a pain, palliative care, critical care, emergency medicine. You can diversify your this thing, and keeping pace with technology and learning it. And it's a pleasure to learn new things. So these are have pre-anesthesia admission clinics and the OP. So these are the various things which will give you a lot of happiness at that time. Next slide. Yeah. So that is why I said it is quite, noise pollution is quite a lot. There are a lot of comments in OR. There are ethical practices, medical legal aspect, what to say and what not to say. There was $500,000 payment in the US for one anesthesiologist who was just giving a monitored anesthesia care for a patient. That patient happened to be a lawyer, and that fellow kept his video on, and he was just having a gastroscopy. The anesthesiologist commented something a little bit nasty about him. So he sued her for that and he won the case. So you have to be very careful not to talk unnecessarily, particularly when you're having the regional anesthesia. Then how do they, critical care doctors, They routinely work in a high demanding environment. Many of them can be a dying patients. You have to really work hard, because I have done that in the last so many years. I can say it is much more difficult to talk to so many people, convince the patient's relatives, and tell them nicely. And your communication has to be absolutely the top. Next time. Next slide. Next slide, please. Yeah. So in the Portuguese ICU, there was about 31%, French about 46%, Australia and New Zealand about 62%, and in the Indian ICUs, our study itself showed 40% burnout in ICU people. Okay, so this is a survey which was done by Dr. Gopal and Karthik. They all, both of my students, and I'm very happy they have done it. Next slide. They have shown that they have done a survey and they have published this in this thing. On this also, there was in VMJ, there was an editorial showing that the critical care people are fairly stressed in this particular specialty in India. Next slide. Next slide. Yeah, next slide. Okay, this is all the same thing which I just put it so that you can go and refer. And these are all the various things, because it is too much of responsibility and lot of patient interaction. And sometimes there is too much of involvement from the, especially in the corporate sector. Lots of things are asked by you to be done. And it is not any time bound. Sometimes you have to do long hours of duty and it is fairly stressful. Okay. Next slide, please. So how can you prevent burnout? I feel from the national authorities, they have to identify. We have to tell them these burnouts can come. What is the thing? So even the early detection by ourselves or anybody else is also important. We should be talking out that, talk to your colleague or talk to your own people around that. How do we improve the work status there? Or how do you do all these things in a proper perspective? So improving interprofessional, interpersonal relationship is very, very important to prevent burnout. That's why I always felt a good team, only you being good will not be of any use. Everybody in the team has to be good and the team has to be united, particularly in critical care. In anesthesia, because each one will be doing, so it is okay. In our department, we'll be together. But in critical care, there has to be really a group has to work together, saying the same thing to all. Next. 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 Okay, this is all I've said. Next one is. So work in a team, share responsibility, have patients come to OP1 so that you feel that you have seen the patients and that they understand that you are the one who saved their life. Communicate well with all concerned. Do not be afraid to tell the truth, both to the patient and also to the, sometimes truth may not be very palatable to many, but I don't know. I lived my life telling the truth. Be ethical and service oriented. Take primary physician into your fold. It is important because sometimes if they are telling something and you are telling something, it will be detrimental to you, the primary physician, and to the patient. And family time and support. But in critical care, what is a little different from anesthesia is a multi-organ super specialist. When you do not understand but undermine. So in interaction with a single organ specialist, sometimes it becomes very difficult. They don't understand the other organs. Okay, cardiologist will only understand the heart. Neurologist will understand the brain. So you as a person between the two, you have to make them understand the whole patient as a. No one will likes to part either with their fame or money. So if you are becoming more famous, they may not like it. Not knowing the patient or the family to win in complete trust. The patient might have come on somebody's name, but you are taking care, but slowly they will know if they have stayed for a little longer time. the corporate sector still not fully comprehend the role of a critical care, and fear of a medical legal aspects. Also, sometimes the critical care people just say, no, I think I want to be a little behind the screen. Next slide. So, anesthesia and critical care and emergency, radiology and lab services are like the 5 pillars, like we have for the Indian Constitution, you have 5 pillars. So, these 5 pillars, without them, all the 5, no hospital will function. So, service-oriented department, they say, but without their service, they cannot run the hospital. There are a large pool of competent doctors, and patient contact is less for radiology and lab. Maximum patient contact is there for anesthesia, critical care, and emergency. Maximum stress without knowing the patients. And it is important that we should have propagate the awareness in the public. Now, with this pandemic, I think we are known better, but most of the time we are at the back in the screens, okay, behind the screens. Next slide. So, in concluding, what is most important, we all have to manage the work stress, and that cannot be got over, but it has to be in a nice team and communicate well. Anything. This is one of the soft skills everyone has to learn, is to communicate with each and every member of your team. And you have to know how to manage the end of life care, how to manage the other healthcare workers. And it has to be made to recognize burnout. If somebody is a little bit sad, find out why they are sad. I mean, I don't know. I keep asking that. Even to people who come and work with me, I keep asking them, why are you sad like that today? Why are you not talking? Is there any problem? Maybe they may not like. If they want to tell, they'll tell. I don't probe further, but I usually ask even my colleagues in that way. Next slide. Next. Okay. Now with the COVID pandemic, the specialties who are in the front line are EMD, anesthesia, critical care. They are really coping with long-term wear of PPE and leaving families and isolating, working long hours, fear of getting COVID all the time, doing difficult procedures which we do normally. The stress will be high and burnout can be faster. So please be aware about it. And then whatever symptoms I have told, kindly think about them. Are they coming? Are you become listless? Are you not communicating? Are you getting a little depersonalized? Think about that. There's nothing wrong. You can immediately think and do something about it or talk to people. Next. So life is nothing but a balancing act. So if you can balance nicely, you don't, it is balancing act even on the, a ball. But if you can balance your life, then you can avoid burnout. Next. Next. Yeah, thank you all for your patient listening online, and thank you ISA Kerala for making such a wonderful meeting.
Thank you very much, Dr. Manimala, for underlining all the factors which cause burnout, especially in the critical care patients, and how best to manage them. I remember one of the articles by Devatia and his group in 2017. They said that 91% of the persons, anesthesiologists who were working in medical colleges, private practitioners, it was very sad that 91% of them said that they had moderate stress. And they were all ready to, and the major reason why it was occurring was because there was long working hours at the weekend. And the second important reason was high-risk cases they were conducting. So they were all ready to undergo stress management programs. So I think now we'll take the questions. Indrani, there are many questions for you. Indrani, are you there?
Indrani,
yes, ma'am.
your video.
Okay, so the first question that comes to you is about that case of kyphoscoliosis. They say why didn't you give TIVA before placing the LMA? Is it possible to have done it with TIVA and not use muscle relaxants?
This was an anticipated difficult airway, right? We are looking into an anticipated difficult airway. So where mouth is open, and why not put in an LMA or a tube? Why not try that first? See, basically, as practically, if you have seen earlier, whenever there was a patchy block, we used to do all this, giving that masala of ketamine and everything. We used to do that. But now we have a good armamentarium in front of us. Here is a difficult case. You have the entire armamentarium in front of you. You have expert help. So why do you want to do that?
Yes, the message is well taken. Another question, a couple of questions which talk about if bag mask ventilation is not possible, should we give neuromuscular blocking agents or should we call an ENT surgeon?
See, calling an ENT surgeon is not negotiable. We have to call them in any case. About bag mask ventilation, I think that I saw some of the thing where the dictum is do not use muscle relaxant if the patient is what is that?
Difficult airway.
Difficult airway. Yeah, difficult. So that was the dictum when we grew up, right? The present difficult airway guidelines tells you precisely that if you have failed with your SGAs, if you are not, and go ahead with bag mask ventilation. For bag mask ventilation, if you are unsuccessful, you have to give a muscle relaxant. Now, question is, why do you want to give the muscle relaxant? Now, here, when you're doing a bag mask ventilation, if there is a functional obstruction, right? If there is an anatomical obstruction, a simple airway, a nasopharyngeal airway, or oropharyngeal airway will sort out your problem. But when will you have a problem? You're not able to bag mask ventilate. When there is a functional problem. So whenever there is an increase in airway resistance or when the compliance has come down, patient has got a bronchospasm, laryngospasm, how are you going to deal that? How are you going to make that as a successful thing? That will happen only if you're giving a muscle relaxant. So in an Indian scenario, I would give succinylcholine. Whereas in the Western world, because it is an auto-reversal agent, right? Succinylcholine is an auto-reversal agent. We do not have Sugammadex, we don't. Otherwise, in the Western world, they have given rocuronium, and in case there is a problem, they have Sugammadex for rescue.
Yeah, so there was one question.
Indrani, suppose, ma'am, but suppose there is you cannot ventilate even after giving the muscle relaxant. Don't you think we are taking too much risk?
It is not at all a risk. In fact, the chances of success is much higher after giving the muscle relaxant than before giving the muscle relaxant.
Agreed. But
because
suppose
they are already desaturating now.
Agreed.
You have done everything now. You have given your best.
There will be few patients where even after giving muscle relaxant, the ventilation may not be possible, and that will be.
So in that case, front of neck access.
So in that
case, have a cricothyrotomy set ready with us.
Or should we go for propofol or some other agent, and then we should try to ventilate?
No, ma'am. No, ma'am. Propofol will only deepen your anesthesia, but a functional difficult airway will not get reversed with propofol.
And more
you have to give a muscle relaxant.
Yeah, more chances of
have to give a yes.
So if you are able to bag mask ventilation is possible, then giving a muscle relaxant, and of course, if your airway cart is ready, that is pretty safe.
Yeah.
Another question is, what would be the dosage in your continuous spinal?
To tell you very frankly, I have no expertise on the dosage of a continuous spinal. but well, I have known certain private practitioners do it because it's not at all as a choice, but if it is an inadvertent spinal intrathecal puncture, so what generally you have to scale down your doses, obviously. So when you are giving a top up, you have to give at least 1/4 or 1/5 of the dose. So if you have given 2 ml, I would give half cc as the top.
Okay, so I would help you out here. Intrathecal bolus dose, we routinely give about 0.5% of bupivacaine and maybe 1.75 to 2.5 milligram of the bolus dose, along with about 15 to 20 mics of fentanyl. And then you start an infusion, and this infusion should be 0.05 to 0.125%, and it is given at a rate of about 0.5 to 3 ml per hour. And what is most important here is that you should be flagging that catheter, that it is a spinal
catheter.
Yeah, so that is very, very important. And unless you can provide absolute aseptic conditions, you should not go in for an intrathecal catheter.
Thank you very much, ma'am.
Other question is for difficult airway and difficult spinal, a CT neck for extent of tracheomalacia in a patient with thyroid swelling, and a lateral view of X-ray neck in thyroid swellings. Comes from Chetna.
It doesn't, there is no two things about it. If the emergency can wait, here my case was a perianal abscess, can very well wait. So you have to do a good evaluation of this patient. The abscess is not the problem. That huge thyroid swelling is the problem. So we have to do a good evaluation, whether it is CT, X-ray, whatever is possible in your institute. We have to do a good evaluation and then only take up this patient. No doubt, no two things about it.
I think those are the only questions there. And for
another question from Dr. Shukdeep Nayak. Is it safe to repeat spinal anesthesia after
giving of the first failed region? Yes, it is done. So if it is complete failure, you can repeat it. As I said, ma'am, there is no what do you call perfect dose.
Yeah.
You have to assess case to case. If there is a patchy block, it depends upon how much has been the block. So depending upon that, you can scale down to half the dose or 1/4 the dose or whatever, depending upon what the thing is. So there is nothing like a perfect, for this you have to give only this much. If there is no perfect dosing when you're giving a repeat spinal. Again, it depends upon a case to case and a lot of factors as to how much is the block, whether there is no block at all, or whether there is some amount of block and how much is the block. So it depends upon all those factors.
So I think if there are no more questions, thank you very much, Indrani and Manimala, and thank you, Manjushri.
Thank you, Sunanda, and thank you, everybody.
Hi. Because there are no questions, because nobody wants to ask, they may think that they are getting burnout. So
no, madam, it was really a very challenging topic. And I think it is very good that you have bring such a topic in this platform, and really you have to think about.
It is the problem of the day.
That is what I'm saying.
Yes.
So we all have to think that the problem is there and we have to address it. So
Yes,
all the
ma'am.
lecturers, please
avoid it.
Avoid and have a consultation early rather than to have the fire. Okay.
And we have
And
to
go to
find
bed.
out our own way to
we have
recover
to.
from such
Yeah.
thing.
Tap out the spark before calling the fire brigade for fire.
Find out the spark.
Thank
Not
you so
when it
much.
is
Thank
dangerous.
you. Now we hand
Okay.
over the
Nice,
proceedings.
Nanda. Okay.
Thank
Bye-bye.
you, Venkatgiri. Thank you so much.
Thank you all, madam. Thank you very much.
Thank you, Venkatgiri. Thank you, all of you from Kerala. Really, I think Kerala is known for matriarchal society. So maybe
Yeah. It is a Pramila Rajya. We call it as Kerala as.
Yes, ma'am. Yes. You hit the nail on the head.
Thank you, madam. Giri sir, Nasser is not audible. We will move on to next session, the last session of today's CME, that is post-COVID scenario by Dr. Lakshmi Kumar from Amrita Institute of Medical Sciences. And I welcome Dr. Sarama madam and Dr. Shamshad Begum, HOD of Thrissur Medical College, to start the session. Sarama madam and Shamshad madam, please.
Good evening,
Sarama
all.
madam, please unmute. And Shamshad madam is also there.
Yes.
Yeah, good evening. Before going
yeah.
to the session proper, it was nice to have Divegar madam with us. I remember I met her first back in 1972 when she came as an examiner. And again, I met Dr. Marimala Rao, Dr. Sunanda Gupta last in 2017 for the Indian College of Anesthesiologists conference at BHU again. Now we have the youngest speaker of the day, Dr. Lakshmi Kumar, and we have got the youngest budding topic which is taking away our sleep, that is our COVID-19 patients. So far we were just bothered about how we'll treat the patient, how we'll go ahead. Now, a number of cases are recovering from COVID-19. Now the challenge with us is that when they are coming for anesthesia, how are we going to manage? And for that one, we have got Dr. Lakshmi Kumar with us. She is HOD, Professor and HOD at Amrita Institute of Medical Sciences, and her fields of interest are gastro, liver transplantation, pediatric anesthesia, and critical care. And she is going to definitely enlighten us regarding this one. And over to you, Dr. Lakshmi.
Yeah, good evening, everybody, and thank you, because I feel tired at the end of a long day. I'm sure everyone listening is feeling pretty tired. Thank you, Dr. Venkat Giri, for the invitation. Normally, it's Binil who keeps inviting me. I don't know whether he got scared that I'd refuse. I'm not quite sure. But thank you, actually, because this made me understand a lot more. In this light, Sarama madam has pointed out to an ever-increasing group of patients where I believe the anesthetist should have a sound knowledge to manage the patient optimally. I'm not able to move my slide. Okay, right. So this is the model in which I'm going to discuss the statistics of COVID infection and recovery in Kerala.
Madam,
COVID affects.
Madam, sorry to interfere. Slides are not visible actually.
Oh, really? Okay, it says I'm slide sharing. What should I do? Stop share and start again?
It's better, madam.
Select the PPT, ma'am.
Okay, I'm stopping share and share screen again. Can you see it now?
Now select the PPT and...
I am, my screen is showing PPT. You're seeing or you're not seeing?
Not seeing.
Okay. Tell me what I'm doing wrong.
Ma'am, stop sharing.
Okay, stop sharing. New share I should do, right?
No, ma'am, minimize this Zoom. Minimize this Zoom.
Wait 1 minute. This is still on. Okay, I minimize.
Yeah. Now in your way you kept the PPT, right? Just open it. Open.
Okay.
Yeah, you can see the PPT, right?
I'm seeing the PPT. Can you
yes,
see?
Now come back. No. Come back to Zoom, ma'am. Come back to Zoom.
Not able to do. 1 sec. Give me a minute.
Yeah.
Okay, I'm on Zoom now.
Yeah, now share screen.
Share screen.
Yeah. Can you find your...
I can.
Yeah, select that one. Yeah.
Can you see me now? Can you see the slides now?
No.
No?
We can see that folder only, ma'am.
Folder to खुला है अभी. New share.
उसमें डबल क्लिक कीजिए. Yeah, yes. Show, ma'am. Slide. Yeah, go to the slideshow, ma'am.
Yeah, I am on slideshow. Can you see my slideshow or not?
We
Now
can
it's
see the
seen.
slides.
Now
Yeah,
it's
we can
seen, Lakshmi. Now it's seen. You can continue.
Shall I?
Yeah.
Now we can see.
All right, thank you. Can you still see or no?
It's perfect, madam.
Okay, thank you, Binal. So I'm sorry for this waste of time at the end of a long day. Okay, so this is my model for discussion, the statistics of COVID infection and recovery in Kerala. Now we know that COVID affects the organ systems, the cardiovascular, the respiratory, neurologic, GI, and perhaps like Dr. Manimala Rao was saying, anxiety and stress related disorders. So what state is our patient when he comes to us for surgery? Cardiovascular wise, respiratory wise, and neurological profile. Now, we say that our patient has recovered from COVID, but can he transmit the infection to us? So what is the infectivity profile? How safe is a healthcare worker when they give anesthesia? I would like to illuminate some of these with some case scenarios intermittently, and then of course, summary and conclusions. And I'd be delighted to welcome inputs and suggestions from the audience. I don't know why they are here. Okay, so the impact of COVID in Kerala. Now, this is a picture I took from the net about 2 days ago. And as I'm moving my pointer, you can see there are about 9.2 million cases, of which 8.64 have recovered all over India. In Kerala, the statistics are 572,000 infected, of which 505,000 have recovered, 2,095 deaths. And you'll see that there is a recovery of about 5,000 patients per day. Of course, the intensity of disease in each of these patients is varied. But if you actually ask yourself, you would agree that the odds of some of these patients presenting to us for elective surgery is rather high. And as I said, to me, the concerns of infectivity from the patient and the risks to which any healthcare worker, right from the anesthesia technician to the anesthesia postgraduate or the resident who's inside, what are their risks of contracting COVID? What is the impact of this COVID disease on the patient in these systems that I've discussed about? Does it add to the morbidity of the patient after surgery? So I'm going to put forth a simple case scenario. I had a gentleman, 83-year-old man. He was the father of a cardiologist from Coimbatore. Known case of degenerative aortic valve disease. He had a bioprosthetic valve replacement done 9 years ago. In 2018, he was diagnosed to have a sick sinus syndrome and he needed a permanent pacemaker implantation. On the 25th of October this year, he was admitted, he had fever and a diagnosis of COVID was made and was hospitalized because of his age and comorbidities. He claims he did not have major symptoms apart from fever for 5 days. While he was admitted, an incidental ultrasound showed an exophytic lesion in the left lobe of the liver. So this was diagnosed to be a cholangiocarcinoma, hilar cholangiocarcinoma, and nearly about 20 or 25 days after the onset of illness, he presented to us for a pre-anesthesia evaluation. He was asymptomatic and the RT-PCR test that was done at our hospital was normal. So as a resident in the pre-anesthesia clinic, should the anesthetist have any concerns? You can see that this gentleman, this X-ray perhaps, yeah, you can see that this is this permanent pacemaker, dual chamber pacing, and I don't know, perhaps this was taken after surgery, so he has a jugular line as well. So do we have any concerns? What did we do and what is to be done? Now, we all know it's a hilar cholangiocarcinoma, so malignancy has a certain urgency or priority listing for surgery. In terms of debility, did he have a cardiovascular involvement or respiratory involvement? History-wise, there is none. And on questioning, he did not admit or he did not state any limitations in his activity since the incident. Gross cardiovascular examination was normal. Chest X-ray was normal, did not show any infiltrates. As part of routine protocol in an elderly with comorbidities, an X-ray was taken, an echocardiogram was taken, which was normal. So we accepted this gentleman with the usual risks for age and comorbidities. He underwent a general anesthesia with an epidural analgesia. Intraoperatively, we chose to avoid a local anesthetic and used only an opioid. He made an uneventful recovery. So it all looks very fine. But this is the same for all patients. What does literature say regarding a morbidity of surgery in a patient who actually has a COVID infection? So a perioperative COVID infection is defined as the occurrence of COVID 7 days before to 30 days after the surgery. And in this international cohort study that I think was published in Lancet, they looked at mortality and the effect of pulmonary complications in these patients who developed SARS-CoV infection in the perioperative period that I had defined. This was a large international multicentric study conducted in 235 hospitals over 24 countries. And this included patients who had had SARS-CoV infection 7 days before surgery or who contracted the virus infection within 30 days of surgery. The primary outcome measure was the 30-day postoperative mortality, and the secondary outcome measure was pulmonary complications. So of 1,128 patients, 74%, that is 835 patients actually had only an emergent surgery and 280 had an elective surgery. Overall 30-day mortality was about 24%, 23.8%. But pulmonary complications occurred in 51% of patients in whom the 30-day mortality was much higher. It was 38. So a male gender, age over 70 years, and of course, higher ASA grades, malignant etiology, and emergency versus elective surgery were identified as the risk factors in this group of patients. So what about so this is in patients who have COVID. What about the patients who have had COVID but recovered? So this is another article again from JAMA where they looked at cardiac magnetic resonance imaging in patients who had recently recovered from coronavirus. So this was done in one country. The number of patients they included was 100. These were patients who did not have any obvious cardiovascular morbidity, but they were just selected after their illness to see if there was any impact on the myocardium. So 100 included patients. The median time between the diagnosis of COVID and the time the magnetic resonance was done was 71 days, roughly about 2.5 months. Of these 100 patients, 66 did not need hospitalization and 33 or 34 needed hospitalization. A measurement of the cardiac biomarkers showed that 71 had mild elevations of the cardiac biomarker troponin T and 5 had significant elevations. Compared to healthy controls, the ejection fraction was lower, left ventricular end diastolic volume was higher, and the magnetic resonance T1 actually is indicative of myocardial fibrosis, and T2 is indicative of myocardial edema. Both were elevated, suggesting that there was a cardiovascular involvement in most patients who had recovered from COVID, not necessarily of the severe variety. These were patients who had actually recovered at home. Probably this leads us to be cautious about these patients and the cardiovascular or the cardiorespiratory reserve when you post them for an elective surgery. Now, most of the talk in COVID centers around the lung. What about the pulmonary sequelae second to COVID? This has come in a Kochi edition of Times of India, and it says that pulmonologists and ID experts have said that several patients, even with mild or moderate COVID symptoms, are returning to hospitals with serious conditions, including pulmonary fibrosis. That is to say, patients who had recovered were having a recurrence of symptoms of respiratory symptoms. Some of them had symptoms of fatigue, and some of them had symptoms of diarrhea, besides minor symptoms like anosmia. Now, what happens in COVID? This is taken from a journal, but I will also show you pictures that are taken from our own patients. This is an X-ray of a patient who has a typical COVID-like picture appearance, a peripheral ground glassing, and the subsequent 2 CT images show the progressive consolidation, the marking air bronchograms and extending areas of consolidation. This is a crazy pavement pattern. And this E and F actually represent pictures of another patient where they say that the distribution of consolidation across different cuts of the lung is not uniform. This is a lower area and this is a upper area. Now, the same article, this is from Thorax 2020, shows on the left side the CT image of a COVID survivor and a study, the CT that was done about 26 days after the onset of COVID pneumonia. You can find that there is a ground glass imaging which is suggestive of perhaps a permanent damage to the lung in the form of fibrosis. And these patients are bound to have some degree of pulmonary morbidity when they present for elective surgery. So it's not always 100% back to normal. You're left with a certain amount of disability. This is our own picture of a patient who was 73-year-old who was admitted in the COVID ICU and made a progressive recovery. And this is a CT images after his recovery, where you can see residual areas of fibrosis and consolidation, which are seen in the segments of the lung cuts. Now, neurological manifestations, I think we do know that they exist, but we don't always remember. Remember that transmission is from droplets and there's a viral entry into the brain as well as immune responses. And they say that in the CT scans, there is a falling out of hair-like receptors on olfactory tissue and the most commonly described symptom of anosmia and ageusia. We've all heard of patients with COVID being more predisposed to Guillain-Barré syndrome. And you know that there is no conclusive treatment for the manifestations, but you just wait and do a symptomatic management. Now, having spoke about 3 system manifestations of COVID, when do I think the hospitals are not going to keep quiet? When do you think it's right time to take a person after recovery from COVID for an elective surgery? This article is from Austin, Texas, again in 2020. And here they say that you need to, do you go by tests or do you go by symptoms? And they say you adopt what is called as a hybrid strategy. Look at both the symptoms as well as look at tests. They say if you had a choice to take an elective surgery, delay the elective surgery for 4 to 6 weeks after symptom onset. You do not have to do an RT-PCR if they are asymptomatic because they are most likely to be non-infectious. If you're taking a patient 2 to 4 weeks after the onset of symptoms, it may be wise to do a test-based strategy. And if you're going to take a patient less than 2 weeks of the onset of symptoms, you don't need to do testing, but in this case, you treat them like a COVID positive patient and take them with full PPE precautions. I hope I'm now. Hospitals, as I said, I have seen at my workplace, there is a constant pressure to increase the number of patients because their revenue is coming down. Our salaries are not being given. So then they say, you need to push yourself and do more work. You need to create more revenue for the hospital and make so money. Get in more patients to our hospital. So how are we going to do this? And the poor healthcare worker is just attiring himself in this most abominable dress, feeling uncomfortable, difficulty to breathe, headache and sweating, wondering what risk he has of contracting the virus and what risk does he have or is he going to give to his family by the spread of his virus as well as his associates. So what is the true nature of the infectivity pattern of this virus? Now the median incubation period is 4 to 5 days. The IQR is about 4 days to 7 days and 98% of the infected individuals will develop symptoms in 12 days. Sorry. Now, viral RNA levels are detectable 2 to 3 days before the onset of the symptoms. They peak at the level of the symptom onset and decline after 7 to 8 days. Both asymptomatic and pre-symptomatic people can actually transmit the virus at a time when they don't know they are positive. Now, we are uncertain about the duration of the infectious period, but supposing you contracted the coronavirus, they say that 10 days after symptoms, And 3 days after the onset of symptoms and 3 days after the resolution of the symptoms is a safe period to quarantine yourself and consider yourself non-infected. This article is come from a Boston School of Public Health. It has definitely changed our concepts about the infectivity of the disease and is being used for the current guidance of management of patients. Now, in this study, it says that many patients can have persistently positive RT-PCR that may persist for weeks or months after clinical recovery. They do not necessarily indicate an infectivity because this is basically a dead virus. Infectivity decreases to near zero in 10 days in normal people and maximum around 15 days in immunocompromised people, and is never found to be infectious 20 days from the onset of symptoms. So based upon this, this guideline suggests that if a patient were to come 20 days after the onset of symptoms, it is not necessary to do an RT-PCR. You can believe that he is not infectious provided he is symptom-free. This is again a picture of the same thing where they indicate a peak viral load activity on 3 days preceding the onset of symptoms, maximum load on day 0 to day 5. Now, almost all studies that have been conducted say that you are unable to culture the virus beyond 9 days from the onset of symptoms. There is a less than 5% probability of culturing the virus in critically ill or immunocompromised people up to day 15. But it is never ever longer than 20 days, right? So even if you have an RT-PCR positive at 90 days, these people are not infectious, is what this guideline says. And there are numerous studies which repeatedly say the same thing. 5 days, 8 days, unable to culture. And then there is something that is called as the cycling threshold. So when the cycling threshold or the number of cycles that your immunofluorescence has to rotate before getting a positivity, if it crosses more than 30, it means that the viral load is really, really low. And this patient is unlikely to be infective even when the RT-PCR is positive. So they offer a similar explanation for a patient who tests negative initially and then positive at a very high cycling threshold, indicating that this definitely just reflects different points of sampling and not necessarily infectivity from the patient. I hope I didn't confuse you there. So let me again put forth 2 case scenarios, and I think my lecture is almost done. A 49-year-old doctor, he had presented with subacute intestinal obstruction in June this year, had undergone a colonic stenting, and this was followed by 7 cycles of chemotherapy that ended in September 2020. He was to come for a surgery, but he tested positive on the 13th of October, and about 10 days later, an antigen test was negative, and he came to Amrita for surgery on the 17th of November. And the surgery that was planned for him was a lap sigmoid colectomy and radiofrequency ablation of the secondaries in the liver. Now, when we did an RT-PCR, his antigen was negative, but the RT-PCR was positive, causing a lot of concerns. Can he come to the main OR? Should he go to the COVID OT? Is this a reinfection or is it a dead virus? Well, this is the way we went about it. His details were evaluated by the ID team who looked at his profile. There was a suspicion that the chemotherapy could have caused an immunosuppression. But was he somebody who was shedding the virus for a longer period? But on evaluation, there were absolutely no symptoms. X-ray was normal, ECG was normal, and hence he was considered not infective, did not manifest any cardiac or respiratory involvement, was taken into the regular theater with level 2 PPE, had an uneventful anesthesia and surgery. Now, all cases are not so easy. A 60-year-old male admitted to another hospital about a month ago with breathlessness and renal failure, where he was initiated on hemodialysis. A diagnosis was a CKD with an acute kidney injury exacerbation. Just after initiating on hemodialysis, this gentleman tested positive on the 30th of October. He was a background of certain amount of immunosuppression, uncontrolled diabetes and hypertension, and he was diagnosed to have an orbital cellulitis, probably a fungal orbital cellulitis, and was brought into Amrita for a surgery at a point where the RT-PCR was negative, roughly about 10 days after the onset of symptoms. Now, we said in the previous case, his chest was okay, his X-ray was okay, and his symptoms were okay. This gentleman was mild. He was hypotensive. He needed vasopressors. His X-ray showed this. It was a haziness of the right side and some degree of infiltrates that was seen on the left side. You can see from his ECG that he has some degree of block, right? And there is some degree of left ventricular hypertrophy according to this. So his ECG is not very straight. He was intubated and kept on a ventilator, and the only saving grace at this point was blood gases looked pretty good. Don't know whether the pH was corrected because of bicarbonate dialysis done on the night before. pH was 7.36, PCO2 was 36, PO2 was 76 on an FiO2 of 0.5. So the anesthetist covering this OT was comfortable taking the patient for, surgery in the regular OT with level 2 PPE. Right? So we thought we are good, and this patient was shifted to the emergency room from which he had been brought, and he was extubated 24 hours later. And about 3 or 4 days later, he was again referred to us for a re-surgery saying the mucor had not cleared. Can you take him for surgery? But at this point in time, our patient had been extubated. He was put on BiPAP, and there didn't appear to be any improvement in the lung signs on the chest X-ray. He desaturated whenever the BiPAP was removed, and we weren't sure why the X-ray continued to be this way. There were financial issues, but perhaps if everything was in order and your RT-PCR was negative, this is one kind of patient where one needs to do a cardiorespiratory evaluation, including a room air ABG, probably an effort tolerance, which is not possible in a man who's BiPAP dependent, and a CT lung to look for any degree of fibrosis or ongoing active inflammation before we could take him. So at this point in time when he came, the patient's family was not willing to consider intubation for the procedure. And I didn't feel comfortable with him on a BiPAP and taking him for surgery with this degree of X-ray changes. So the case was actually deferred to a later date. So one more patient that I just like to bring to your attention. So you can probably realize we are having a steady stream of post-COVID infections who come into our management. 52-year-old healthy liver donor in August 2020, after a very uneventful surgery, was shifted to the ward on day 3 and was brought back the same evening because of distress and hypotension. So obviously she needed emergent resuscitation with IV lines, fluid replacement, a blood gas and arterial line was inserted. At that time, the BP was on the lower side, around 70 to somewhere between 70 and 76. Her arterial hemoglobin was 5.5 grams. She just took a central IJV axis single lumen that was converted to a triple lumen by the time the OT was being arranged. And she underwent a laparotomy for a bleeding on the posterior surface of the diaphragm. The bleeding was controlled and she was shifted back to the ICU, right? But 3 days after this, the intensivist found that she was not improving in lung symptoms. Her X-ray was not looking good. So they decided to send a chest X-ray which appeared to have features of peripheral consolidation. And she was diagnosed to be COVID positive. And she also happened to infect a couple of our healthcare workers and put a lot of us in quarantine for that period. So what was her course after contracting COVID? She needed intermittent NIV. In all this process of supports and multiple stress, which includes a bleed and management and a pneumothorax that needed an ICD, she developed a stress cardiomyopathy. She needed a colonoscopy because she was dropping hemoglobins and ended up getting a rectovaginal fistula following, right? And she underwent a surgery for an exteriorization colostomy. Now this lady, at the time when we dealt with this patient, this paper on infectivity was not out. So we believe that as long as the patient tested positive, they were infective. So there were no clear guidelines on how long. So she remained for up to a month in the ICU, COVID ICU, because her RT-PCR continued to be positive. And after a period of negativity, she was quarantined for 7 days as per the older guidelines. And she was taken into a COVID OT because we didn't have another OT. one surgery for exteriorization, and subsequently when she was negative, a closure of the colostomy were done. So this lady really had a traumatic and very dynamic surgery and its aftermath, but luckily made an uneventful recovery at the end of this ordeal and went home. So to summarize whatever I've been trying to say, correct management of patients post-COVID infections is only emerging, and therefore as evidence collects, our management and understanding is only going to slowly improve. But data that has come out at this point definitely has evidence to say that a patient who has recovered from COVID may have cardiovascular, respiratory, and or neurological sequelae. Hence, an anesthetist who is in the pre-operative screening clinic should look at patients specifically for evaluation of cardiorespiratory symptoms, which may include a breath holding time, a 6-minute walk test, a room air a saturation, or a room air ABG, and more intense cardiopulmonary evaluation as may be needed. Should the respiratory system consistently come out with some features of, say, respiratory distress, tachypnea, or abnormal respiratory function tests, a CT may be indicated for the evaluation of pulmonary fibrosis. In this context, an echo may also be mandated to look for evidences of pulmonary artery hypertension. Now, one thing that we have understood is that the patient is unlikely to be infective beyond 20 days. It may be just a waste of our resources to repeat the RT-PCR in them, even if the patient were immune compromised. So again, as I mentioned before, the cycling threshold, RT-PCR positivity after 30 cycling thresholds is unlikely to be infective and represents a very low viral load. And as more and more data emerges, the impact on the disease on the patient and optimum management systems may be clearer. So this is where we are. There's a waterfall and we're like a bird flying between it. We need to stay safe and hopefully we'll get clarity on the correct management. Thank you very much.
Thank you, Lakshmi, for the excellent presentation, because you have covered almost all, but I want to say something more. I have a question. Before that, there was one question in the chat box, that is whether the need for a spinal anesthesia, regional anesthesia may be given or not. Okay.
For COVID,
post-COVID.
So I think whenever possible, if you can minimize any exposure to aerosol, I think a spinal anesthesia would be, a regional anesthesia would be the first choice.
Regional anesthesia guidelines in post-COVID patients, and how do they differ?
And there are guidelines for post-COVID. This is my intuitive thought regarding what should be the management.
Okay.
With the COVID coming, all of us know that, when we can, we avoid any intubation or exposure to aerosols. So I guess if I had a choice to do a procedure under a spinal or a block, I would go for that before intubating.
And another question is the role of supraglottic airway or LMA with the spontaneous ventilation instead of controlled positive pressure ventilation with the endotracheal tube in post-COVID patients.
Right. So here the thing that they need to remember, so these are all airway people and they don't know, I'm not an airway person, but these are finer details. You must remember that after 20 days, they are not infected. So you can choose whatever. You shouldn't have to try a supraglottic airway or put your hands through a COVID box to make an easy intubation difficult. Then you're actually exposing yourself to aerosol. So know your technical expertise, ability, the need for support, and whatever is optimal, quick, least trauma and least exposure to you and other healthcare workers should be ideal. Truly, there is no recommendation regarding supraglottic airway devices that I came across while reading for this.
Yeah, another question is, ma'am, what do you suggest for a patient plan for emergency tracheostomy in ICU and has tested COVID IgG antibody positive with a 4.26 value? What does this value signify if the patient is giving it no history of any symptoms? That is plan for emergency tracheostomy.
Okay. So again, why is he needing an emergency tracheostomy? Is it for causes related to COVID or otherwise? So So if he has an antibody, it just means that he has had a prior exposure and is temporarily immune perhaps from COVID. Would he be infective? If he has no symptoms, I'm not sure about the infectivity status of this person. Actually, now that the question is asked, my thought process is racing. I don't have a clear answer to that. All I would know is if the antibody were positive, he has had an infection and has mounted.
Yes, that's it. Okay.
Right? So,
yes.
He needed an emergency tracheostomy. I guess I would do with taking level 2 PPE prophylaxis and minimizing aerosol exposure. I would think that he is infected.
Yes. Last time also the same thing has happened. Whether they can infect or continue with the process or not. And another question is, see a tongue with meds with the carbon dioxide narcosis. What is it? I couldn't understand. See a tongue with meds with the carbon dioxide narcosis. Thank you.
So what? Who has COVID or who's
yes,
COVID?
it's not mentioned. The role of rapid antigen test versus RT-PCR in preoperative patients.
I don't know how you would manage the airway. Just like you would manage a patient with CA tongue and CO narcosis without COVID. So I guess, however the patient's airway is and whatever, if you need a front of neck access or if you're able to, use a video laryngoscope, if you want to do a fiber optic, I guess that would depend upon the expertise of the patient. I truly wouldn't know the most correct answer. This is what I'm telling from what appears to be the practical approach to that problem.
And another question is, do you suggest giving hydrocortisone during surgery?
There are no guidelines regarding supplementation of hydrocortisone to COVID patient, post-COVID patient.
And the role of rapid antigen test versus RT-PCR in preoperative patient for elective surgery. Role of rapid antigen test.
So that's again individual institutions. We choose the RT-PCR test because it's the chances of us missing an inadvertent infection is less than the antigen, which actually has a number of false negatives. So RT-PCR is superior to a rapid antigen testing, and it is employed as a protocol of choice at my institution.
That is in the initial stages. After that, that is to some maximum of about 20 days. We are not supposed to do it.
To do a test. You really don't have to do a test if they're asymptomatic.
After 20 days. Okay. Okay, then another thing is that a question that occurs is difficult vascular access. There is more chance of thrombosis will be there. Arterial thromboembolic phenomenon will be there.
So when the patient has had COVID and they say that the pulmonary and the cardiac manifestations are partly secondary to that, among the groups of patients we have seen, there's been nothing that we are able to directly correlate saying that these patients are more predisposed to thrombosis or that their coagulation profile is deranged. It's probably a microvascular thrombosis that we are talking about. So I guess you need to be cautious, and if there is no risk of bleed, consider some kind of low molecular weight heparin as prophylaxis perioperatively.
And there is a chance of hypercoagulable state also. Sometimes the patient may go in for a hypercoagulable state, and the vein thrombosis may also occur if the patient is remaining as prolonged blood development.
Right.
Okay. Okay. So I think no more questions are there. And Lakshmi, it was very good. And congratulations to the whole Binil, Isaac, Nazar, sir, and all, because it was really interesting.
He didn't call me. Why he made Dr. Venkat Giri call me?
Okay, you have got so many of the cases, isn't it?
He
Because
was
nowadays we
scared
are
to call you so
getting.
many times. He was scared to call you.
Oh, I thought so.
He told, this time I should call you.
Giri, it was good again. Congrats to the main, that is the main background for all these stages and all.
Thank you. See, even now at this late hour, both Divekar madam and Manimala are there. Manimala madam is 76. Divekar, I think must be more than that. And our other chairperson speakers are also there. Elsa madam is there, Sunanda madam is there, Jayashree madam, all are there now. Madam Indrani is there, and Rebecca madam has told that she has some other program after 8 o'clock. She has already, beginning only she told she will not be available after 8 o'clock, and she wanted to some other program. And it is great that they all have attended and participated till the end. We wanted to have all the seniors together at one time. So thank you all for that, both the chairperson speakers and staying till the end of this thing. And we have our senior members Chakra Rao and Kameshwara, our regular visitors.
Sir, so many seniors are there. They can unmute and ask the questions if they want, and they can express their comments.
Now we will have some 10 minutes of free time, and 10 o'clock we will close. Now it is 9:50.
Madam Sarama, madam, may I have some questions also?
To unmute.
Madam,
Unmute, ma'am. Yes.
Madam Lakshmi.
Yes, ma'am. Yes, ma'am.
Yeah, nothing else.
Madam, it's unmuted, but it's not audible.
She's not audible.
Okay.
Audible?
Yeah.
No, madam.
Yes, now audible.
It's audible.
Audible.
Madam is audible now.
All the questions have been asked, and it is well done by Dr. Lakshmi. Nice to see you, Dr. Elsa. Thank you very much, and congratulations to all ISA organizers. Thank you.
Okay.
Thank you, madam. Thank you.
Shall we wind up?
Before that, if we will expect some more questions. Chakra Rao sir maybe wants to add something. Sir, please, you can unmute and talk, sir.
Where is he? Can't see you. Chakra Rao, where are you?
Sir just called me and he got some announcement.
Yeah. Right.
Yes,
Good evening.
sir.
Sir, unmute, sir.
Sir, it's unmuted.
Okay. What shall I tell? I'm very happy to see all the
old women,
all the renowned lady anesthesiologists. Namaste, madam. Madam. Namaste. Namaste, madam. Mrs. Divakar.
Thank you.
Dr. Sarama, Shamsad Begum. And actually, I am the person who has made the lady anesthetist group.
Yeah.
I should have conducted this meeting, but these people have hijacked all of you from me. It is an excellent actually program.
Yeah, come in.
And of course, you all people well versed in all this. You are almost, of course, you are not a teacher to me. You are just 2-3 years seniors to me, but I regard you as my teachers. And especially, of course, Mrs. Divakar, when I went to Mumbai for the conference in 1984, she was already a very high of herself. And of course, Mandamala madam, we have almost all the regards. I hear a lot of things about Shamsad Begum and other people. Thank you very much for an excellent organization. Of course, people like Indrani and our pediatric anesthesiology, 2 pediatric anesthesiologists, they have done an excellent work. Let us all work together in the development of the Indian guidelines. We are writing or updating the Indian resuscitation guidelines again. Please cooperate with us. We will all work together and bring a better guidelines. As we are at the doorstep of ILCAR, they are ready to accept us. Thank you very much, madam. Thank you.
Kameshwara garu.
Thank you, sir.
Hello.
Thank you, ma'am.
Yeah,
Namaste,
I
madam.
think it is such an excellent get together of all our old
Yes.
people. Yeah.
After a long time, even I could see Manjusri madam. But
Manjushri, yeah.
she never appears in anything. Namaste, madam. Jai Shri madam.
Hi, madam. Rebecca, madam. Hi.
Actually, it's a really wonderful. I mean, it's a very rare thing you have brought up. You know,
It's good.
unique, unique thing in the history of anesthesia. ISA. Very good.
You created history when you became the first group president of ISA.
Yeah.
Right?
Long live ISA.
Thank you.
Yeah.
Right. Thank you very much, everybody. It was really was all the talks, very good, and I so enjoyed it. I sat through each one of them, so really
Wonderful
enjoyed
to
it.
meet everyone.
Excellent.
Yes.
Excellent.
Yeah. Right. Good night, and everybody stay safe.
Yeah. Good night.
Thank you.
Okay, Sananda.
Good night, everyone.
Okay, Elsa.
Leaving now.
Yeah.
Thank you, madam.
Anything else to add, Giri sir?
See you.
Nothing. Today's inaugural dinner is at your house. Today is the inauguration of our annual conference. So we all should have been there in Ahmedabad.
Oh,
So I remind you all that this time. So thought that this 26th we should have a CME. Otherwise, morning was a full-time CME day, and we didn't have that opportunity this year. So have this CME and the inaugural program time, and we will have it next year.
Yeah. So actually, you have the unique experience of being president-elect for 2 years. I think that this is happening in 1973 when we had, I think.
no, actually in 78, Dr. Venkatara has become 2 years president. And again in 82 or something like that.
Dasgupta was there.
Dasgupta also became because of the that mosque problem.
Yeah. Ayodhya.
And concluding remarks to Nasser sir. Over to Nasser sir for concluding remarks.
Yeah. That was really a wonderful evening with of interaction. We really enjoyed it. I am really thankful to all the speakers, all sessions for bringing out a lot of highlights into such a wonderful clinic. I thank you on behalf of ISA Kerala. Thank you all. See you. Good night.
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 The meeting is closed.
Thank you, madam.
Thank you very much, everybody. Thank you so much. Good night.
Good night.
Good night.
Good night. Stay